So this is the second one. Initially we conducted Sarvasrushti sir under. So this is the second one we are conducting. So it's also going to be interactive session. The first one, curves and graphs, was very good. It was a hit actually. So under Sarvasrushti sir guidance and Venkatraman sir guidance. So now the second session is going to come here. So please interact to the maximum. Okay. So with this, we'll start the sessions. Dr. Shishi.
Good morning, everyone. Hope everyone had a pleasant day. This is an interactive session, and to start the session, first speaker will be Dr. Shankar Vallapu, and he is going to decode the labs in organ function. Now I request Dr. Shashikiran and consultant nephrologist and Dr. Bharat Kumar, consultant gastroenterologist, to chair the session. Yeah. Dr. Shankar.
Good morning, everyone. I am Dr. Shankar Vallapu, intensivist in Yashoda Hospital. So, I am starting with decoding labs of biochemistry involving organ dysfunction. So, let's start now. I am going to discuss 10 to 15 scenarios. We have around 3 to 4 minutes for each scenario, and try to interact for each and every scenario. It's like kind of question and answer basis. Okay, so coming to scenario 1, this is a 56-year male, known case of diabetes, ESLD, related to hepatitis C since 10 years. He presented with increasing ascites, respiratory failure, decreased urine output since 1 week. He had admission 10 days back where they did large volume paracentesis with albumin replacement. He received antibiotics and they stopped diuretics, which he was on for ascites. On examination, there is acute distress, jaundice, patient is jaundiced, abdomen is tense and non-tender, bilateral lower limb edema, hearts and lungs were clear, patient is hemodynamically stable, neurologically within normal limits. So these are his lab parameters. Can you see the lab parameters here? Any abnormality over there? There is a rise in creatinine from 1.3, where in the last admission, to the 2.4. There is deranged liver function test, thrombocytopenia. Ultrasound shows normal sized kidneys and chronic liver, cirrhotic liver, there is ascites, and spot sodium is less than 20. Urine protein is less than 0.5 gram per deciliter. What is your diagnosis based on this? Why are you calling this as hepatorenal syndrome? Why not any other cause? What are the possibilities here? We have to rule it out from what are the cause of renal failure? Pre-renal, renal and post-renal. We have to divide like that. After excluding all. So they should not, it is a kind of diagnosis of exclusion actually. Here HRS comes into picture when if you exclude all other causes of renal failure. Okay. So to exclude, we have criteria. So these are criteria for HRS. What are the criteria? Patient should have cirrhosis with ascites. There should acute rise in creatinine. Within 48 hours, the creatinine should be more than 0.3. There should not be shock. There should not be hypovolemia. There should not be any nephrotoxic drugs. No parenchymal renal disease. How can you say parenchymal renal disease is present or not? RBC and no RBC in urine or less RBC. One more thing, less proteinuria. Normal ultrasound picture. Okay. So this is a hepatorenal syndrome case. What is the treatment of HRS? definite treatment is liver transplantation. But as a bridge to therapy, if the patient is not eligible for transplantation, terlipressin and albumin is considered. These two drugs are have proven that they have definite role in the management of HRS. One is terlipressin and other is albumin. What is the mechanism of terlipressin and albumin? Albumin causes volume expansion. The main problem in HRS is circulatory dysfunction. Because of splanchnic vasodilatation, there is circulatory dysfunction, decreased renal perfusion pressure, which causes the decreased output and increased creatinine. So the main mechanism of action is volume expansion. Terlipressin causes vasoconstriction in the splanchnic circulation. So there are two types of HRS, HRS1 and HRS2, but now they are called as HRS-AKI, HRS-AKD and CKD. So depending upon the response to treatment, it is divided into no response, partial response and full response. If the creatinine reduces less than 0.3, that is the less than 0.3, that is full response. The creatinine goes on increasing, that is no response here. If it is not increasing but stable, more than 0.3, that is partial response. So coming to scenario number 2. He is a 79 female, she is a 79 female, known case of hypertension, diabetes, presented with acute coronary syndrome. They did primary PTCA. After 24 hours, her creatinine rises from 1 to 1.5. After 3 days, it subsides to normal. Patient discharged on day 4. 2 weeks later, she presents to emergency with bilateral lower limb pains and discoloration in the toes. Okay, this is scenario. So this is a picture of her lower limbs. Picture of foot. You can see there is a discoloration. Based on the history, what is your possibility? This history. These are lab parameters. So there is discoloration in limbs and raised creatinine with mild rise in the creatinine kinase. Our urine examination shows eosinophils, granular cast, RBC. So which of the following is what is your most likely diagnosis? Any idea? I will give options for you. Out of this, one is the answer. Which is the most likely? Which is most likely? Why not diabetic nephropathy? Why not contrastive nephropathy? Why not others? Diabetic nephropathy will not cause so acute rise in creatinine. Contrastive nephropathy, there is initial increase in creatinine, that is contrastive nephropathy, usually resolves by 2 weeks. Pigment nephropathy, the creatinine kinase is very mildly raised. So to call pigment nephropathy, it is not fitting to criteria. So the diagnosis here is arterioembolic disease, renal disease. So how do you confirm your diagnosis? There is a hypocomplementemia because cholesterol causes activation of complements and leads to decreased complement levels, and other is kidney biopsy to rule out from other cause of nephritis. Coming to scenario 3, 62 female diabetic on metformin, regularly takes NSAIDs over the counter for knee joint pains, presents with fever, rash and hematuria. Sorry, he is a male patient. So this is a picture of the skin lesions. Can you identify any lesions there? There is a maculopapular rash over the body. Rash with fever and hematuria. This is a lab parameter shows like this. The rise TLC, acute kidney injury is there. Eosinophils positive, pus cells present in the urine. Depending upon this, any diagnosis or anyone? So the picture shows here, picture of interstitial nephritis, because there is a classical eosinophiluria and WBC cast, eosinophilic cast with raised eosinophils in the peripheral smear and rash over the body, which fits into allergic reaction to certain drug, some drug. What is the offending drug here? NSAIDs. Most commonly attributed to acute interstitial nephritis is NSAIDs. So how do you treat it? Stop the offending drug. Whatever the offending drug is, you have to stop it. Consider steroids and other support treatment. Coming to scenario 4, a 24 female was on alporic acid for new onset seizures. She takes sports supplements, including anabolic steroids for heavy weightlifting. She is brought to the ER with vomiting, headache, acute altered mental status, and intubated for worsening lethargy. So these are lab parameters. Anything you identify? What is abnormality here? High serum ammonia. And toxicology screen is negative. CT shows cerebral edema.
Cause
Good.
We want interaction. Then this will have some penetration. Otherwise, none of you will remember even a single idea. If somebody answers, somebody interacts, then the things will go into your neurons.
So the possible diagnosis here is hyperammonemia caused by valproic acid leading to cerebral edema. So what are the causes of hyperammonemia?
Carnitine deficiency. Patients who have carnitine deficiency will have hyperammonemia with valproic acid.
Yes. And the other thing is that we should rule out urea cycle disorders also.
Yes, sir.
There is a we have to rule out other CLD features.
Yes, sir.
The
Here
GI
liver
bleed,
is
sepsis, and
normal.
other things we have to rule out because these are the causes of hyperammonemia. So there are hepatic causes and non-hepatic causes. So the diagnosis is cerebral edema secondary to valproate induced hyperammonemia. What is the treatment? So you have to stop the drug, okay? Change alternatives and carnitine. What is the mechanism of carnitine here? Actually, valproate uses carnitine for its metabolism. In the absence of valproate, it produces toxic metabolites which are toxic to the liver and alters urea cycle mechanism leading to hyperammonemia. So carnitine replacement will cause proper oxidation of valproate. If the concentration of ammonia is very high, consider dialysis. Coming to next scenario, she is a 30-year female, primary, 36 weeks of gestation, is admitted with right upper quadrant pain, nausea, vomiting, malaise for the past 2 days. ANC was normal, no past medical history, no drug or alcohol abuse. On examination, patient is tachypneic, tachycardic, no signs of liver disease. So this is the history. These are lab parameters. Based upon the history and lab parameters, any guess? I want 2 common diagnoses based on this history and the lab parameters. 2 common DDs. Anyone? What all you can observe there? There is a raised transaminitis. Transaminitis is there. Coagulation profile abnormal. Platelets are low. WBC is elevated. AKI is there. Pregnant lady.
Sir, HELP syndrome, sir.
LDH is normal there. What are the possibilities? 2 common diagnoses. Yes, other day, HELP syndrome. Is it fitting into HELP or not? Why? LDH is low, there is no picture of hemolysis. Okay. And other investigations are normal. So the 2 common DDs here is HELP and AFLP. Which of these fitting into criteria here? What is the criteria for HELP, for AFLP? To diagnose here, what is the criteria used? Yes, Swansea criteria. So here, The Swansea criteria will have clinical features like suggestive of nausea, vomiting, abdominal pain, encephalopathy. So the laboratory features like there is a raised bilirubin is there, hypoglycemia is there, AKI is there, ammonia is high, urea is high. So this fitting into AFLP. So what is the treatment? Definite treatment of AFLP. Anyone? Termination of pregnancy, irrespective of gestation of age. Okay. What is the outcome if you terminate pregnancy? What is the outcome? Usually results to normal within 7 to 10 days. Most of the cases result to normal. Coming to scenario 6. 60 men admitted with yellowish discoloration of eyes, pale stools, and pain abdomen. No history of fever or drug intake prior to onset of symptoms. LFT results are as follows. Please observe the LFT. Any abnormality there? There is mild transaminitis with elevated ALP and GGT. What further investigation you order? Take mic and answer, please. Yes, ultrasound. We'll do ultrasound. Rule out cause of. You are not able to identify an ultrasound. What will you do further? You'll do endoscopic ultrasound or MRCP. Okay. So you found some obstructing callus in the distal common bile duct. So the cause here is, diagnosis here is obstructive jaundice. Treatment, what is the treatment? ERCP to remove the stone. Good. If there are stones in the gallbladder, what will you do? Will ERCP followed by cholecystectomy. Coming to scenario 7. 40 male epileptic develops the following abnormal liver function test 5 days after starting treatment with phenytoin. Any abnormality you find there? Try to answer, please. Based upon the history and diagnosis investigations, what is the most probable diagnosis? Most likely one diagnosis. Yes, drug-induced liver injury. What are the types of DILI? There are cholecystatic and hepatocellular injuries. So what is this case fits into? Is it cholestatic or hepatocellular injury? How can you say hepatocellular or cholestatic? Yes, depending upon the rise of ALT or ALP. If the ALT is more than 3 times of upper limit of normal and the ratio is more than 5, it suggests hepatocellular injury. Our case fitting into drug-induced liver injury. So what are drugs causing DILI? Most common drugs causing drug-induced liver injury. Halothane, carbon tetrachloride, acetaminophen, phenytoin as our case. There are some drugs causes chronic liver failure like atorvastatin and methotrexate. Coming to scenario 8, it's a common thing and I think most easy diagnosis here. A case 68 male, recent treated for pneumonia, now present with right side pleural effusion, loculated pleural effusion. Pleural fluid analysis given below. Simple. Yes, exudative. Okay. What is the cause for exudation here? Mostly empyema. Okay. And this is empyema thoracis. What is the treatment for empyema thoracis? Decortication, ICD. Yes, ICD, decortication by thoracic consultation. Scenario 9, 59-year-old lady with ovarian cancer. After chemo, she presents with abdominal pain, nausea and anxiety. So these are lab parameters. Second, what is the case here? Yes. Why are you saying tumor-like syndrome? High LDH and the picture fitting into tumor-like syndrome. What is the treatment? Hydration, proper hydration, allopurinol rasburicase, and diuresis. There are two things. One is laboratory TLS and clinical TLS. What is the clinical TLS? Clinical TLS. The abnormalities causing into some organ dysfunction like high creatinine leading to renal failure, cardiac arrhythmias, sudden death, seizure. Laboratory abnormalities with one of the clinical picture leads to called as clinical TLS. The more than one of the below is present, it's called clinical TLS. Coming to scenario 10, 45 male presented with severe headache and drowsiness. NCCT brain was normal. 2 days later, LP was done. Headache, drowsiness and CT shows normal. LP shows the following picture. Can you identify anything there? I already highlighted for you. Simple, please answer.
SAH, sir.
Why not it is traumatic tap? How can you differentiate both between traumatic tap or SAH?
C to WBC ratio.
That is to differentiate between meningitis and this. Both will have same picture. Meningitis will have RBC to WBC ratio more less. Here you have to ask for xanthochromia. Because it is 2 days. It takes 6 to 12 hours to lyse the RBC to produce xanthochromia. So the differentiating feature would be xanthochromia. If there is xanthochromia, it more fits into SAH. So how will you know? How do you proceed further? If there is SAH, what will you do next? You have to look for vascular cause of SAH. By doing
CT angio.
CT cerebral angio. Good. Scenario 11, 68 female who was on treatment for UTI for past 1 week is brought to casualty department in confused state. On examination, there is a hypothermia and bradycardia. Lab parameters are given below. There is a hyponatremia, hypoglycemia, rise in creatine kinase and high cholesterol level. Respiratory acidosis present on the background of hypothermia and bradycardia. What is the cause here? What is the most likely cause? There are several causes, but most likely cause. If you see this case, how will you treat in ER? Mention 1 or 2 common diagnoses. It is a what investigation you want to confirm. Are you going to thyroid profile or not? It is a thyroid profile and look out for hypothyroidism and also look for adrenal insufficiency. Okay, this is a case of mixed edema coma. What is the treatment?
IV thyroxine.
We don't have IV thyroxine. We have only oral tablets. How do you treat? How many tablets you give? How much dose you give? 300 to 500 mics given through Rell's tube. Okay, and observe for the response. There can be associated hypoadrenalism, so we have to treat along with the steroids and collect samples for both thyroid deficiency and adrenal insufficiency. Okay, and always give slow warming, rewarming. Consider IV fluids, giving IV fluids. How do you assess for response to treatment? Just check for the mental status, stabilization of vitals, and T3 and thyroid profile following up. Coming to scenario 12, 34-year-old lady, known case of rheumatoid arthritis on irregular treatment, brought to ER in semi-conscious state. There is abdominal pain, hypertension, which is not responding to IV fluids. Lab parameters are given below. What is the most likely cause? Any two differential diagnoses? Adrenal crisis. What is the precipitating? What could be the precipitating cause? She was an irregular treatment. Known case rheumatoid arthritis. Probably she might be on steroids. Because of irregularity, she presented as adrenal crisis. And there could be precipitating event can be sepsis. Okay, this is a case with adrenal insufficiency, possibly because of sepsis. How do you treat?
Hydrocortisone.
IV hydrocortisone or dexamethasone. Okay, and treat the precipitating cause. A 22-year male construction worker admitted 2 days ago for treatment of left lower limb both bone fracture. He is requiring increasing dose of opiate analgesia despite immobilization. So the pain is persistently increasing. Okay. 2 days, today he was noted to have dark urine.
Rhabdomyolysis.
High likely it is a rhabdomyolysis. So for that you need some diagnostic picture. So these are the lab parameters here. What are abnormalities you can see? High creatine kinase, hypercalcemia, hyperkalemia, and AKI with mild metabolic acidosis. So how do you treat?
Fluid resuscitation, and if metabolic acidosis is increasing, we have to go for dialysis.
So what is the role of bicarbonate here? Or do you consider bicarbonate or not?
No.
No?
Not proven therapy.
If there is metabolic acidosis, if the pH is less than 7.5, there is proper urine output is present, we can consider giving bicarbonate. If the creatine kinase is more than 5,000, and it's persistently rising, there is some role of bicarbonate. Is there any role of mannitol?
No, sir. No.
There is no convincing evidence, but people still consider giving mannitol if the creatine kinase is more than 30,000. But before giving mannitol or bicarbonate, they should look for, is there any oliguria or anuria? After establishing proper output, then only you have to consider giving the bicarbonate or mannitol. What is the dose of bicarbonate you give? You have to give 0.2 milliequivalent, 0.5 milliequivalent per kg. If it is normal saline, mixed into 1000 ml of normal saline. If it is dextrose, 1 milliequivalent per kg, you can mix it. You have to establish output at least 200 to 300 ml per hour. And what is the target for urinary alkalization? It should be more than 6.5. Before giving bicarbonate, anything you look for? What is the problem with bicarbonate?
Calcium, potassium.
Yes, you have to look for
potassium and calcium.
especially calcium. It can cause hypercalcemia, leading to hypocalcemia picture. So before giving bicarbonate, always look for the calcium levels, and always measure calcium levels every 2 to 4 hours when you consider urinary alkalinization procedure. And consider fasciotomy and release of any pressure. If it is not resolving, go for dialysis. Coming to scenario 14, a 53 male, known case of hypertension, type 2 diabetes mellitus, coronary artery disease, presents to emergency department in confusion and combative state. This is tachypneic and tachycardic. This is lab picture. Most common diagnosis, simple diagnosis.
HHS.
Why not DKA?
Bicarb is 21 and not much acidosis.
Sugars are very high.
And sugars are high.
Serum osmolality is high. So these are differential diagnosis of HHS versus DKA. So our case fitting into HHS. How do you treat?
Fluids and insulin. Fluids and insulin.
IV hydration and give insulin. Look for hypokalemia, correction of potassium, and treat the precipitating cause. And there is a risk of thromboembolism in these patients. Always consider giving thromboprophylaxis in case of HHS. Coming to last case, she is a 48 female, brought to ER in febrile and confused state. She is cachectic. Tachycardia is there, hypertension is there. Our blood tests are presented below. What are the differential diagnosis with this picture without blood test?
Hypertensive encephalopathy, press.
Yes.
Press syndrome.
Any other? She is having AF also. I didn't mention there.
Cardioembolic stroke.
Okay, anything else?
Septic encephalopathy.
Anything else? Hyperthyroidism, pheochromocytoma, there is a possibility. Okay, neuroleptic malady syndrome, there is a possibility. So these are possibilities. So these are lab parameters. So this is a hyperthyroid. Why you are saying hyperthyroid? Because I have given thyroid profile there. No? This is a hyperthyroid crisis. How do you treat? Beta blockers, non-selective beta, especially non-selective beta blockers like propranolol and propyl thiouracil or carbimazole to reduce the thyroid hormone synthesis, leukocyte and iodine contrast to reduce the release of free from thyroid hormone. Consider steroids. Okay. If there is airway disease, consider guanethidine or reserpine in place of propranolol. Treat the precipitating cause and supportive therapy. Avoid salicylates and furosemide. Thank you. Thank you, sir.
It's very interesting, given the variety of case scenarios that you have presented. Now, session is open for discussion. Anybody can, you're all requested to participate in this. So, okay, let me take the initiative so that you can follow later on. Like you have presented one patient with NSAIDs who has used it for a long time.
Yes, sir.
You have presented one scenario of renal failure because of NSAIDs. For the benefit of all the students, like, can you discuss any other mechanisms by which NSAIDs can cause renal failure apart from interstitial nephritis?
NSAIDs can cause acute papillary necrosis by causing medullary ischemia, and also it can cause acute tubular necrosis. So these are other things which causes which can mechanisms which can cause renal failure in NSAID using people.
So acutely, apart from interstitial nephritis, papillary necrosis also can be one of the cause for renal failures, where even though there is no prolonged intake of NSAIDs, even 1 or 2 tablets of NSAID can cause renal failure. That is one scenario. Like there's another interesting case of fatty liver of pregnancy that you have shown to us. Like for the benefit of students, briefly about the pathophysiology or what's the cause for fatty liver of pregnancy and when do we see this?
I want this answer from students. What is the mechanism behind AFLD? Anyone, please? Any defect which is Srikanth, you have any idea about it? What is the mechanism behind acute fatty liver of pregnancy? Shilpa, Dr. Anita, Mahesh. We are happy that for first session so many students are there, but we want active participation. The upcoming topics are too much interesting actually. Actually, it is long chain fatty acid dehydrogenase, LChat deficiency, which causes abnormality in fetal fatty acid metabolism. This causes release of fetal abnormal fatty acids into maternal circulation, which are toxic to the liver. And also it alters the urea cycle disorders in the mother. So this is the abnormality in the fetus causing problem in mother.
Mostly seen with male fetuses rather than female fetuses.
Yes, sir. Thank you.
Just from the intensive care point of view, we just wanted to know from you, sir, being a nephro-critical care specialist. Many of the intensive care setups, we see olivuric renal failure being a common cause, either ATN or ischemic thing or a septic nephropathy or whatever. But whenever we see a patient who is putting a urine of 1.5 liters to 2 liters, still my creatinine is rising, my azotemia is worsening, not great of acidosis. Is it a time where we should think about interstitial nephritis in them, and maybe not NSAIDs being a common phenomenon in ICUs where we prefer other form of opioids or other alternatives? What are the other confounding drugs which we commonly use in the form of pantoprazole, very commonly abused drugs, I mean to say. So what is your experience on them? How do we investigate them when a patient is non-oliguric in an intensive care center, but worsening on azotemia?
Most of the times, the decrease in creatinine in a patient who has got a good urine output, that is non-oliguric, it lags by 4 or 5 days. So we generally wait for that period. Maybe it's the part of the spectrum where the urine output first increases, and over
a patient never had oliguria, putting urine, but the patient's azotemia is worsening in an intensive care center.
See, interstitial nephritis can be caused by any drug. You name any drug from amoxicillin, it can be caused by any drug. So we have to look for other parameters where, if at all, to implicate that drug as a cause. And any interstitial nephritis or anything because of a drug, then if the offending drug is not withdrawn, it continues to worsen. So in a case where there is a worsening of the clinical picture, then we have to actively investigate in that case. If the azotemia is not worsening, in the sense the creatinine increase is not very high, there is no doubling over a 24-hour period of time, urine output is good, probably sit tight and watch for these patients. Remove all the offending drugs. One of the drugs that you said is pantoprazole. There is too much of literature as far as pantoprazole is concerned in the recent past. Most of the literature is biased towards long-term use, not for short-term use. Again, as I said, any drug, whether it is pantoprazole or any drug, can cause interstitial nephritis, technically. But we hardly see anything which is significantly going on in this space. Another thing which is probably one of the reasons where patient is non-oliguric and azotemia is not decreasing can be an increase in the dose of, or a relatively higher dose of diuretics. Suppose if the patient is on any diuretic, if the diuretic dose is a little bit high, more than what is necessary, then that comes in the way of the drop in the creatinine values where the urine output is good. These are a few of the common things that we see.
Is this eosinophil or eosinophil cast in the urine in an interstitial nephritis?
It depends on the lab. Hardly we ask for it. Most of the times there are few drugs which are very much implicated as far as these concerned, and once we see those drugs we try to stop those drugs. Otherwise, looking for eosinophils in urine, it all depends on the lab thing.
And biopsy, how frequently practically we practice biopsying this patient?
If the renal failure is worsening, then that is the case to perform a biopsy. Any situation where it is unexplained, where we find the renal failure is worsening, even though we have a suspicion of acute interstitial nephritis, because those are the cases where we need to actively treat with steroids. So we have to perform a biopsy for those patients if it is not decreasing.
If I am permitted to add few points, the sensitivity of eosinophiluria in acute interstitial nephritis is only 67%, and eosinophil casts are only seen in 42% of the cases. The reference is Nature Review article in acute interstitial nephritis, drug-induced acute interstitial nephritis. Second thing, where you are looking at non-oliguric AKE, is predominantly drug induced, could be aminoglycoside induced or a colistin drug induced. So antibiotics are something that we need to consider when we are using non-oliguric AKA as well as. And coming to the point of non-oliguric AKA as a sole cause of acute interstitial nephritis, usually as cause of acute azotemia, you need to think about a scenario where these patients, they usually come with a lot of comorbidities. You will have ARB usage, you will have PPI usage, you will have other antibiotics which are going to contribute to dehydration with, in terms of amikacin. So all these things, they contribute as a multifactorial etiology where acute interstitial nephritis initially will get converted into an acute tubulointerstitial nephritis. So subsequently you may see that the urine output is reasonably preserved, but still the serum creatinine may be getting elevated.
Thank you, organizing team, for giving the opportunity. Thank you, moderators.
One small point, if I may add.
Yes,
Sorry
sir.
to-
Yes, sir. Thank you.
So, I mean, it's a nice presentation.
Thank you,
So
sir.
one important thing which I wanted to add is, we usually ignore the value of creatinine when we see patients as outpatient or when some patient with cirrhosis comes to emergency due to some reason. So the most important thing is their muscle mass is very less. So if you go by your 1.3 creatinine or 1.5 creatinine, many other people may not have that value. So we generally ask for serum creatinine electrolytes for every visit when they come to OPD. The reason being, if you have a baseline value, if at all the patient has a baseline value, if more than 0.3 milligram per deciliter increase is there from the baseline in the past 48 hours, or more than 50% increase from baseline in the past 2 weeks, we can make a diagnosis of AKI, not HRS. Okay? So based on that criteria, many people will fit into AKI. So one most important intervention which we can do is to avoid stop diuretics at that time and avoid any offending medications which can cause worsen AKI. And if the patient is hospitalized, we actively, or if the patient comes to ER, we reload as BP because it's it doesn't present with any symptoms usually. Some people may have very non-specific diarrhea, or some people may have elevation of creatinine as the sole manifestation. That's one thing which we need to be careful. So to make a diagnosis of HRS, we need to stop diuretics, give volume replacement, and if creatinine doesn't improve, then we make a diagnosis of HRS and think of terlipressin, albumin, and all these things. And regarding AFLP, there are few differentials which we consider in the last trimester of pregnancy. When the lady in last trimester comes with jaundice, so the most important thing is AFLP because it's life-threatening, and if the treatment is termination, irrespective of the week of gestation or maturity of the fetus, because saving the life of mother is more important than the fetus at that point of time. Second thing is HELP syndrome, because HELP syndrome people are usually very sick. AFLP and HELP are very sick. They usually come to ER. Third thing is viral hepatitis. Hepatitis E virus can cause liver failure in pregnancy. So the fourth thing is a benign condition. They come to OPD, like cholestasis of pregnancy. So among these things, AFLP, the differential diagnosis is very important because the treatment is completely different. For AFLP, the diagnosis is termination. For HELP syndrome, plus or minus termination, but we can wait on medical management. For sepsis, treatment is medical management. For cholestasis of pregnancy, we don't do anything. We wait and watch, reassure them. So we need to make a diagnosis because most of the features are overlapping in that scenario. So some people may even, using the Swansea criteria, they are not very specific for AFLP. So some people may require a transjugular liver biopsy for confirmation. If you see microvascular steatosis, then we actually can make a confident diagnosis like that.
Thank you for input, sir. I'll conclude session now.
Now I invite Dr. Shashikiran, nephrologist, to present a token of appreciation to Dr. Shankar Vallabhu. Now I request Dr. Saroj Prusti to present a token of appreciation to Dr. Shashikiran and Dr. Bharat Kumar. Thank you. Thank you, Dr. Shashkiran and Dr. Bharat Kumar.
So, thank you, Dr. Shankar, for that excellent session. So now we'll proceed with the second session. So I would like to invite Dr. Shashkiran Reddy, our consultant critical care medicine, Yashoda Hospitals, Malakpet. To moderate this session, I would like to invite Dr. Sudhakar sir, our senior consultant nephrologist from Yashoda Hospitals, Malakpet. And I would like to invite Dr. K.C. Mishra sir. He is HOD critical care at Yashoda Hospitals, Somajigoda.
Thank you, Dr. Kaladhar. Good morning, everyone. I don't see any interaction in this interactive session. And this is our day and night. We see all these disorders in ICU. That is the reason this was designed. And most of you might be knowing all this, but this is a brushing up of your knowledge and anything new. Yeah. Good morning, everyone. To start with, this is a 78-year-old man who was brought to the hospital after being found down by his daughter at his home this morning. He was functional baseline, was last seen normal yesterday morning. He was recently diagnosed COPD and CNS-wise lethargic, has unsteady gait and confused, vital stable. His on examination his JVP is normal, has a decreased air intake at basis. CT head shows normal, age-related atrophies. Other than that, nothing is shown. And this is his CT chest, and these are the lab values. Going with the lab values, anyone to interpret these lab values? This is a day in and day out case. Yeah. SIADH. Yeah, this is SIADH. Day in and day out we see all these cases. How do you say it as SIADH? Yeah. 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 How do you evaluate a case of hyponatremia to start with? What is your starting point? Where do you start? Evaluating the patient of hyponatremia. Yeah. How do you classify a patient to start with? First one will be volume status. First one will be volume status. Hyponatremia or hypernatremia. You start with how is his volume status? Yeah. This patient is JVP is normal, euvolumic status, and serum osmolality is low. And urine osmolality is disproportionately low or high? Low, to call it as a SIDH. Yeah. And what will be the effective intervention here? How do you intervene in this patient? This scenario, how do you intervene? First thing, the patient came in a state of lethargy, unsteady gait. What will you do? First, what will his management? How do you classify hyponatremia? Symptomatic, asymptomatic? Is it symptomatic? What will you do first? Symptomatic hyponatremia, first thing you should do is assess the volume, then start giving
hypertonic saline.
Then comes the next question. How do you administer hypertonic saline? What are the various ways you administer hypertonic saline?
If the in risk of seizures, we can give bolus of 100 ml of 3% NaCl.
Yeah, 100 ml bolus you can give. How much value does a 100 ml of 3% saline raises? Only one is answering, the rest are all mute. Shilpa. 100 ml of 3% NaCl increases your serum approximately in a 70 kg man by how much? 2 to 3, not so much. We'll be worried if it increases by 5 milliequivalents. 2 to 3 they say. Yeah. And this is the easiest equation you can calculate how much amount of saline you decide to give. How much ml per hour you decide to give. This is an easy formula which I have found out. And yeah. What is the significance of a patient comes to you? Forget the scenario, a patient comes to you. Newly onset of the SIADH, what is the significance of the SIADH? That SIADH, how significant it is? Yeah, cause should be known. 18% of the time you find some tumors, some carcinoma. That is the significance of SIADH. They started going retrospectively. You find a patient with SIADH, you start digging out for a carcinoma or other causes. Yeah, these are the common causes of SIADH. Carcinomas, pulmonary disorders, central nervous system disorders, and others. Most common will be bronchogenic carcinoma and CA duodenum, CA ureter, thymoma, and pulmonary disorders. All your pneumonias, tuberculosis, aspergillosis, and central nervous system are also common. Encephalitis, meningitis, head trauma, Guillain-Barré syndrome, and there are almost everything which involve SAH, Rocky Mountain spotted fever, cerebrovascular accident. Others include AIDS and acute intermittent porphyria. Yeah, these are the criteria which commonly people use to diagnose SIADH. Decreased effective osmolality, inappropriate urine concentration to the serum concentration, elevated urine sodium, and normal renal function in absence of hypothyroidism and cortisolism. That is the reason why we do these two tests to rule out these two disorders, hypothyroidism and hypocortisolism, before calling it as a SIADH. Okay. Yeah, this is a severity based on the severity: mild, moderate, severe. Less than 125 is severe, less than 130 is moderate, and less than 135 is mild. There is a correlation between your hyponatremia and your symptoms, and also between duration. Usually 125 till usually acute. Okay.
Sushi, if I can interrupt.
So
why do you think lung pathology is very important in SIADH? Why you are diagnosing most of the lung pathologies associated with SIADH? ADH is secreted in the brain, as we all know. Why do you think lung pathologies are more important in SIADH?
Lung pathology, most of the ADH is mostly secreted by the tumors of the lung. No. So,
any other explanation for that?
Any other explanation?
So most of the times whenever we see SIADH, we usually look at lung pathology as a cause.
Yeah.
So like aspergillosis or pneumonia.
So
any pneumonia per se can cause or precipitate SIADH. In an acute scenario where you are giving adequate fluids, supplementation is there. So one proposed mechanism is the destruction of ADH happens in the lung.
Yeah.
So whenever there is a lung pathology, there is less likely to have a metabolism of ADH. So it can get aggravated or it stays longer, the T half becomes more. So it can act more on the tubules.
Some say that it also secretes, some tumors do secrete ADH.
Yeah, some tumors do. Even a pneumonia per se can cause. It need not be always a malignancy, but pneumonia per se can cause.
This is a simple formula to calculate how much amount of 3% NaCl you can give based on the body weight. And after 12 hours starting of correction, sodium is found to be 140. You are worried about the osmotic demyelination syndrome. How do you proceed? What is the next step? Someone, Mahesh? How do you proceed from now? How do you go about? Whether it is want to look at what was the situation? Was it an acute or chronic?
It was acute.
What do you do in acute and what do you do in chronic?
chronic we don't
Because I am
usually-
elaborating this is the most important salt in the body.
Acute, if it is symptomatic, the correction should be aggressive in order to prevent the seizures. Chronic, we usually go slow on correction.
Acute, you have corrected from 120 to 140. Are you worried? Acute state, very
Definitely.
acute. See, where do you find acute states? Acute hyponatremia. Tell me 2-3 scenarios. Acute hyponatremias. Surgery. What surgery causes acute hyponatremia?
TURP.
Want to look at TRP most commonly? What all cases you see acute hyponatremia?
Brain, traumatic. brain-
Ectasy, and also you can see acute hyponatremia. In those scenarios, you need not come back. You go up to 120 to 140, you need not come back. Within 48 hours of within 48 hours of the hyponatremia has been occurred within 48 hours, you need not come back acute. In a chronic state, you have to come back to, depending on the risk factors of ODS. What are the risk factors of ODS, you know?
Older age group, diabetic patients.
Yeah, not this I have displayed on it.
Alcoholism and malnutrition.
Alcoholism, malnutrition, sodium concentration less than 105. And how do you go with this? This is a scenarios where you try to come down and where you don't want to come down. Acute water intoxication, and acutely have raised. Brain must have not accumulated effective osmoles, idiogenic osmoles. So you need not go down. Need not go down after correction. And in a chronic state, depending on the risk factors of ODS, you need to relower based on how risk the patient is at. If the patient is at high risk, you go down to the lower level of correction, that is 8. If it is moderate risk, you go down to the upper level of correction, that is 10 to 12. How do you desalinate the patient? What are the strategies you use?
Free water.
Encourage to take more water if patient is awake, conscious, and you can give 5% dextrose. Okay. Depending on symptoms, this is a mode of treatment. Severe symptoms, coma, obtundation, and seizures, respiratory distress, and vomiting. Despite of anything, first start 3% NaCl, then assess your volume status. Then you can use either Vaptans or fluid restriction, either of this. Moderate symptoms, if the patient is euvolemic, you can go either fluid restrictions or Vaptans. And hypovolemic, you can give some you can give some isotonic saline. That should be enough. And no or minimal syndromes based on your volume status. Again, volume status is very important. The first step in assessment will be volume status. And hypovolemic patients, always give normal saline. Euvolemic patients, you can give either Vaptans or fluid restriction. Hypervolemic patients, you can try Vaptans. And take home from this is evaluate before correction. Difficult to ascertain the duration. This is a very important thing. It is very difficult in ICUs to ascertain the duration. How long is hyponatremic? Avoid multiple interventions at a time. Avoid giving 3% saline and 12 Vaptans, what we use commonly. And judicious use of vasopressin inhibitors and monitor frequently. Monitor 4 to 6 hours should be a monitoring period. And yeah, that's it. So anything to add, sir?
Observed in many of your ICUs, your levels will further drop or remain same. Then there will be another discussion here in your ICU round. So probably we are giving less of 3% normal saline, so we increase it from a 15-20 ml to 30 ml or a 40 ml, and you observe after another 12 hours it further drops or remains the same. You go on doing this for some more time. Have you observed this in your intensive care unit in many of the occasions? So just I wanted to highlight that issue, because now
to diagnose SIADH, even we say ki the serum osmolarity, urine spot sodium, urine osmolarity, but they all take time. They will not be on board. Volume status has its own task of identifying the euvolemic state, hypovolemic or hypervolemic state, even though you have a clinical and devices to identify them. So this is one way where it should give you a clue that if my 3% normal saline is not helping my patient, am I dealing with SIADH? A asymptomatic, stable patient where I'm trying to replace with 3% normal saline, because it is not just a salt or a sodium related abnormality, it is a water related abnormality. So do I need to restrict water in these patients, which may help in them? So I just wanted inputs from you, sir, as a moderator in this.
No, it is what you told, Dr. Venkat, is we have seen, like, if not in 100% of cases, 20-30% of cases, we see similar kind of thing, not like decreasing, but the sodium will not increase even after starting 3% normal saline. If you are thinking that the patient is not euvolemic and you start a normal saline and 3% normal saline both, most of the time if somebody is presenting with, let's say, hyponatremia, and most of the hyponatremic patient will have some symptoms if it is significant. If it is less than 115, they will have some deficit in concentration and all that we don't know. Most of the time we don't check, and few people will come obtunded. So we give two things, normal saline and 3% normal saline in most of the cases. What I believe, as Dr. Venkat told, if you are giving both and sodium is not increasing or sometime it drops, in that case you have to think of SIDH and start restricting fluid. If patient is significantly hyponatremic, let's say sodium of less than 115 on 110, irrespective of their symptoms and all, you have to correct it because it can precipitate a seizure. So if less than 110, we have to correct it. At least it has to come to a reasonable number. If you believe by giving normal saline sodium is not improving, in that case restrict fluid. Most probably it is an SIDH. And even SIDH also will have some fallacies. Sometimes it will be difficult to know that volume status in a patient. It's not always that easy to see that it is euvolemic or hypovolemic.
The other change which, yeah.
The only other close differential would be like when you are dealing with an ICU, especially neuro ICU, where you feel it's a SIADH and you are not very sure, it's a cerebral salt wasting. Cerebral salt wasting. Yeah. So it appears more like an SIADH, but in these cases you can give, yeah, and it improves. So if it is improving, it is looking like SIADH, it is improving with your 3%, probably it's a cerebral salt wasting in neuro ICU scenarios. Otherwise, it's an SIDH, and as you said, to restrict.
Some people say cerebral salt wasting is an enigma. Is it true, sir?
There are definitely a section of people who say that cerebral salt wasting is not a real entity.
Real entity.
But there are equally good number of people who say that it's an entity because here it is acting against your SIDH protocol of treatment where you need to give.
Yeah.
So these discussions are always there. But in a practical scenario where we are dealing, if something is getting worsening and you feel it is an SIDH but it's not behaving that way, probably you're dealing with cerebral salt wasting.
Yeah, so one will be responsive to the volume and saline, the other will not. So, and in a context where you have both under the differentials, this is the way. The other point which I really wanted to emphasize is, gone are those days where a symptomatic seizure, comatose, obtunded patient comes to you with a sodium of less than 100, less than 110, less than 120, you chasing with 10 ml, 20 ml, 30 ml by your calculation. Those days are gone. We are now giving boluses of 3% normal saline that may vary between 100 to 200 ml. It may not be restricted to 100 ml, maybe 150, and repeating after 1 hour of time. As you said,
the maximum dose they say 500 ml, sir.
So if you repeat after an hour or two and your sodium is still behind a rise of 2 or 5, then you can repeat another 100 ml. So we are again chasing against the disadvantages of that low sodium causing neuronal injury versus a probably osmotic demyelination. So we are weighing the risk and benefit. These are the patients who had a high risk of getting damaged by the hyponatremia causing the neuronal injury. So here, the rise need to be given by a boluses of volume, 100 ml, 150 ml and 200 ml, and repeat another after an hour or two. I still see a very, very low percentage of this practice. I still a patient on a coma receiving 200, 220 ml, 30 ml infusions going on.
Yeah.
Hyponatremia, sir. Usually what could be the most common cause?
Most common scenario that we encounter for hyponatremia causes is a diuretic use.
Diuretic.
So elderly patient who comes, who has been on hydrochlorothiazide or chlorthalidone is the most common cause. So most likely you are looking at a hypovolemic hyponatremia as the commonest cause for ICU admissions or hospital admissions in ER.
So is there any cutoff value for the serum sodium in these patients, like we don't have to treat acutely, or
depends upon scenario. See, by the patient, when he comes to an ER, more likely he has symptoms. So that is an indication to admit and treat. If the patient is being seen in OPD and routine parameters are showing a serum sodium of 124 or 128 where the patient is asymptomatic, all you have to do is properly hydrate him, and probably if the blood pressure is well controlled, you can take out the diuretic. So these are the two things that we need to do, and reassess his mentation. Basically, most of the asymptomatic patients have very subtle symptoms of difficulty in walking, frequent memory losses, or frequent falls. So these are the things which we need to assess in OP, need not be always in ER. So probably depending upon the symptoms, you can decide whether we need to treat him or not treat him.
A patient with mild headaches and body aches also, they say now to treat it.
Yeah.
Yeah.
No, there is a dictum. They say that if sodium is low, you should not think that patient is asymptomatic. If you see closely, there will be some symptoms, but most of the time we miss. We always believe that if somebody is hyponatremic, he will be obtunded or unresponsive, something like that. They will have some concentration deficit or something. We most of the time don't check. That is one. And regarding second thing is in SIDS treatment, that is the tolvaptan. At what level you want to give, the problem with the tolvaptan is, if you, let's say, we have seen all these scenarios on and off. Let's say sodium is 110 or something, we start off tolvaptan. You will not have a control over your sodium. Next sodium will do, it will jump to 120 also. So tolvaptan, when you need to start, and is there anything, guidelines?
Tolvaptan, only euvolemic, FDA has approved only for euvolemic hyponatremia, sir. And yeah.
SIDS, you are suspecting SIDS,
SIDH.
you want to give tolvaptan. At what level you want to give? And is there any caution need to be applied when you are giving tolvaptan in cases in ICU, symptomatic hyponatremia with very low sodium?
I would like to not, once the symptoms are improved, I will not like to start parallelly. If the patient is symptomatic, once let me improve the symptoms, get me euvolemic, and then I would like to, if it fits into the criteria of euvolemia, I would like to start the tolvaptan. Around 120, get it up to 120 and then start tolvaptan.
Most of the times, whenever you label somebody as hyponatremia and want to treat, you want to see a target of 125 and less.
120.
So label him as hyponatremia. So if he is symptomatic, our target of correction is only 120. We don't go beyond 120. We stop at 120. That is number one. Hydrochlorothiazide, the reason why hydrochlorothiazide, as rightly said by Dr. Sudhakar, the reason why hydrochlorothiazide is such a weak diuretic causing hyponatremia is because it acts at the terminal end of the sodium absorption. So if you cut off the sodium absorption at the terminal end, there is no further correction for the nephron where it can take it back. Even though furosemide is so powerful, it acts before the terminal end. So it acts at the loop. So whatever sodium is still being excreted, there is the distal nephron which tries to capture all that sodium and you don't see. Whereas in this case, patient may not be dehydrated, but he will have hyponatremia because there is no further correction as far as this is concerned. So that's one important.
One more point to add is furosemide, like sir has told. Furosemide knocks off the medullary interstitial tonicity as well, whereas hydrochlorothiazide doesn't take out them. So when the medullary interstitial tonicity is knocked off, similar amount of water is excreted in proportion to sodium. So there won't be additional water retention as it happens in hydrochlorothiazide because the medullary tonicity is well preserved. So there will be a dilutional hyponatremia in addition to loss of sodium, which happens with chlorthalidone or hydrochlorothiazide, whereas similar torsemide doesn't cause, or furosemide doesn't cause it.
Sir, this is a third scenario. A 26-year-old previously healthy G1P0 and female at 36 weeks of gestation comes to emergency department with polyuria, nocturia and polydipsia. Vitals are stable. Physical examination wise she is normal except for loss of skin turgor and dry mucous membranes. And the notable lab values are, and his urine osmolality is 89 and serum osmolality is 308 and serum sodium is 157. Can anyone tell me what is the diagnosis? Mahesh or Srikanth? Answer. What do you think of this pregnant coming with high sodium? What do you think first and what is your diagnosis? Seeing sodium of 157, what do you think first? You have to interact. Already we are behind time. Clock is ticking. Serum sodium is 157. What can it be? Someone at the back would like to answer. Yeah. Okay, what is this? What is this phenomenon? No. 36 weeks of gestation, there's a catch point. What is your diagnosis? How do you again classify this? Hypernatremia. First diagnosis will be your hypernatremia. What is the cause of hypernatremia? What do you do in hypernatremia then? Next, assessor. Volume status. You have to see whether it is solute diuresis or water diuresis, first thing. Okay, and then hypervolemic hypernatremia. There are only 3-4 causes. Saline infusion, which we do commonly in ICUs, and soda bicarb, hypertonic dialysis, first degree aldosterone Cushing syndrome. This is euvolemic is diabetes insipidus. This diagnosis is 36 weeks of pregnancy. Catch point. No, there is no history there. Gestational diabetes insipidus. Why does this happen in pregnancy especially? Because placenta releases vasopressinase which lyses. There is a catch here. ADH is low. Your ADH is low. 0.5. Placenta releases vasopressinase which lyses vasopressin and causes gestational diabetes insipidus. Okay. And how do you manage acute? How do you manage and chronic? How do you manage? Acute you can give full correction. 0.9% saline is still tried. Can be still tried. And more than 48 hours, you have to go slow. You have to correct it over 2 to 3 days. Water deficit, the most common formula most of me might be knowing. And let us move on to the next scenario. Please try to be interactive.
Yeah, just a second. What are the 3 things you will see when you say it to be DI, diabetes insipidus? Let it be central, nephrogenic, or gestational. 3 things. Anand?
How do you treat this condition?
No, how will you diagnose first? First you have to diagnose, no? When you should suspect a DI, that's all. There are 3 things.
Polyuria, low urine osmolarity, high serum osmolarity.
First is hypernatremia. Sodium has to go up. Then there will be urine osmolality which has to be less than 100. Third?
High serum osmolarity.
Polyuria. If these 3 things are there, we think it to be DI. If their brain is involved, we see it to be central. We don't do ADH in all cases. Do we do ADH in all cases? No. If these 3 things are there, you need to suspect DI. Then as per the symptoms and history, you need to decide that it is central, nephrogenic, or somebody is on lithium. It can be nephrogenic diabetes insipidus. somebody of, let's say, significant brain damage, it has to be central diabetes insipidus. In this case, pregnant patient, gestational, so it's a gestational diabetes insipidus. You need to pinpoint on what is the diagnosis. Then you can make out what is the cause of this.
Yeah, how do you treat this gestational diabetes insipidus? Quickly. What do you give? Normally, what do you give? In diabetes insipidus, in neuro ICUs, lot of time you give. Srikanth.
Desmopressin.
I want to give vasopressin. Are you okay with that? Okay. You can't give vasopressin because again vasopressin lies by your vasopressinase. Only desmopressin works here. Scenario 4. An 18-year-old man comes to emergency department and complains of severe muscle weakness and dizziness. SBP is 94 and orthostatic change. Curves for Chinese food with added salt. He complains of arthritic changes in the knee. And X-ray shows calcium deposition. Catch points, hypotension, carving for salt, and calcium deposition in your knee joints. Okay. Going to the labs. What do you see in the labs? Sodium of 137. Next catch is potassium of 2.9, bicarb of 30, blood pH of 7.8, and urine calcium of 50 mg. Normal urine calcium is around 100 to 250. What is this? I am giving the options. 5 options. 3 can be ruled out straight away. 3 options. Liddle's hereditary mineralocorticoid excess and acquired mineralocorticoid excess are ruled away straight away because patient's BP is normal and his orthostatic is usually these 3 disorders present with hypertension. Remaining is Gitelman and Barter's. What is this? Gitelman or Barter? What is the main difference between Gitelman and Barter? I given a values, I given a clue. Urine calcium will be more in Barter. Hypercalciuria will be there in Barter. Hypocalciuria is there in Gitelman. Okay. How do you evaluate this hypokalemia again? I'm just going to just go through this. I'll just go into the next case scenario. How do you treat mild, moderate, severe? Mild you can treat with oral supplements. Sir. Sir, the next scenario, a 71-year-old alcoholic man is admitted with profuse GI bleed requiring 12 units of packed cell volume. His calcium dropped from 9.2 to 6 with normal magnesium levels, catches normal magnesium levels. His inoid calcium is on a lower limit of the normal. Your liver function tests are slightly elevated. Deranged liver function test. What do you think of it? 4 choices: hypercalcemia due to liver disease, hypocalcemia due to blood transfusion, hypercalcemia due to transfusion-related coagulopathy, none of the above. What can it be?
C.
Why? Okay, give me 2 reasons why it is C.
Citrate toxicity.
Yeah, why should he have citrate toxicity? Liver is abnormal. Okay. This is workout for hypocalcemia. Just I put a slide. You can go through this. And what is the relation between hypomagnesemia and why do you want to look at magnesium? There is a point there. Look at magnesium. Why do you want to look at magnesium? When a patient is having hypercalcemia, what are the potential consequences of hypomagnesemia? Magnesium is required for the secretion of PTH. In a patient with hypomagnesemia will have low PTH and low calcium. Okay, that is the reason why you have to correct magnesium first to look into the diagnosis of hypocalcemia. Okay. Next scenario, this is a 60-year-old man brought to ER with altered mental status. Physical examination showed confused and well-developed male with labored breathing. Vitals are stable except for the lower extremity ulcer, which is wrapped up with a bandage. containing white powder. Rest of the examination is normal. And you see the values, the marked up values. Calcium is 9.2, albumin is albumin is 2.7, correct, and pH is 7.69. Short QT interval. What do you suspect? What do you suspect? Urine calcium is 150. Very confused, labored breathing, wrapped with a bandage of white powder. I am giving the clue, calcium carbonate is a powder. What can it be? Someone should interact. Here are the choices: sarcoidosis, milk alkali syndrome, familial hypercalcemia, occult malignancy, and thiazide. What can it be? Simple. Calcium carbonate, I have given a big clue. Milk alkali syndrome. Okay. These are the clinical manifestations, and these are the, yeah. How do you correct this? What is the treatment goals on hypercalcemia? Treatment goals, someone should interact. Shilpa, what are the treatment goals? What do you do first? Hydration. How much do you hydrate? How much deficit will there be and how much you hydrate? Quickly, there are other topics also in the line. Okay, I'll go ahead. Okay, a 60-year-old thin woman, concentrate on this, thin woman, colon cancer with a colostomy, comes admitted for a poor oral intake, weakness, dizziness and weight loss. She is receiving chemotherapy. The oncologist wants to start her on 2000 kilocalories per day. You should start diagnosing from here, most of you. Serum chemistry is normal. And to start with, after starting of the feed, you have repeated the labs. Potassium is 3.1, calcium is 7.8, magnesium is 1.8, and phosphate is 1.1. What it could be? Quick. Refeeding syndrome. Good. And how do you define it as? This is you can note down this definition. I found it somewhere. And what are the causes, etiologies of refeeding syndrome? Mostly prolonged starvation. You starve a patient for 4 or 5 days and start him on feeds. You are more bound to refeeding syndrome. Nasogastric suction, homeless, metastatic cancer. These are all the complications of your refeeding syndrome. They can have severe rhabdomyolysis and death. There is a how do you treat moderate hypophosphatemia? You can treat with oral supplements 1 to 2 mg per deciliter, and severe sodium phosphate 15 millimoles intravenously over 2 hours you can give. Yes, sir. Yeah, this is the last scenario. A 59-year-old female with a history of hypertension, gout, is admitted to ICU for observation status. Post-thrombolysis for ischemic stroke. He's on metoprolol, colchicine, aspirin, metformin, and meloxicam. Heart rate is 108 per minute. Low bicarbonate on lab. ABG done. This is your ABG. Someone interpret it. Shilpa, try to interpret it. What does the ABG look like? Last scenario. Someone should be interactive.
Sir, scenario once, sir.
Scenario 1 once, yeah.
Yes.
Hypertension, gout, admitted to ICU for observation status, post-thrombolysis for ischemic stroke. Drugs she is on: metoprolol, colchicine, aspirin, metformin, meloxicam. Heart rate 108 per minute. Low bicarbonate on labs. That is the reason why you have done ABG. Okay, ABG shows the following values: pH of 7.3, potassium of 5.9, bicarb of 18, urine electrolytes. Someone interpret this. Urine osmolar gap. What is the diagnosis? Chronic diarrhea, type 1 renal tubular acidosis, type 4 renal tubular acidosis, and Bartter syndrome. What is the diagnosis? Quick, loudly. It is type 4 RTA. Type 4 RTA. Okay. 49 minutes.
Thank you, Shashkiran. I think we had a good interaction. Quickly for 1 minute, anything to add, sir?
No, I think we have interacted enough.
Yes. Thank you.
One
Thank you,
small
sir.
suggestion, sir, with all the critical stalwarts are there, critical care stalwarts. Why don't you introduce a fluid team to manage fluid for our patients in ICU? Someone to look after fluids, predominantly fluid intake. That's a big problem for us.
Thank you, sir. Definitely, sir. I think from now onwards we should concentrate on that. So the thing is, next we'll proceed with the next class. So we, for a token of appreciation, Dr. Sudhakar sir, to give a token of appreciation to Dr. Shashkiran Reddy. Certificate. So Dr. Venkatraman sir, to give token of appreciation to Dr. Sudhakar sir. Dr. Venkatraman sir, next one sir, second one. To give token of appreciation to Dr. K.C. Mishra sir. Thank you. I think slowly, class by class, the interaction is increasing. We need some more interaction. So with this, we'll start the third session, decoding the toxidromes, the beginning. For this, I would like to invite Dr. Sai Kiran. He is our consultant critical care at Yashoda Hospitals, Malakpet. To moderate this session, I want to invite Dr. N. Ravishankar Reddy, senior consultant gastroenterology at Yashoda Hospitals, Malakpet, and Dr. Shishita Reddy Gupta is our senior consultant physician at Yashoda Hospitals, Malakpet. Thank you, sir. Proceed.
Thank you, Karadhar sir. Good morning, everyone. I am Dr. K. Sai Kiran. Over the next 1 hour, we are going to have a brief roundup of the toxicology cases. My colleague Dr. Prasad and myself, over the next 1 hour, we are going to present around 16 to 18 clinical scenarios with the relevant findings and lab investigations, and we would like you to tell us what the toxin is. I'm sure all of you are great doctors. It's time for the Sherlock Holmes within all of you to come out now. Let's look at the first case. A 28-year-old male presenting with 3 weeks history of loss of appetite with odynophagia, 1 week history of decreased urine output and mild breathlessness, a weight loss of 3 kilos, probably due to decreased intake. On examination, the patient was conscious and oriented. There was mild neck edema, otherwise no stiffness. Clinical examination, the only significant finding was mild hypoxia. He was saturating at 84% at room air, while the BP and heart rate were all right. On oral examination, this is what we found. This might be a giveaway for most of our Yashoda students, but I would like some non-Yashoda students here to give any comment. Because at Yashoda here, we see a lot of these cases. So I would like our Yashoda students to stay quiet for a while and give opportunity to the others. This is a very, very characteristic finding, which is a giveaway. Can you have this light off?
There is nothing big deal in those
Light.
These are all common toxins which can come in and out. Some of the patients where you see this kind of erosion, when you say there is an erosive toxin, it can be an acid, it can be some alkali, it can be some toxin which can cause erosion.
You can see large ulcers with a necrotic base. There are huge fissures in between with minor bleeding points. And the tongue also is edematous. We'll come back to it. I'll give you more clues to come at it. So we were suspecting some ingestion. So we went ahead and did an endoscopy also that revealed mild edema and few esophageal mucosa and hyperemia without any erosions. Routine blood investigations were done. And the significant findings you can see here. The renal function tests were grossly damaged. The creatinine was 6.8 with a blood urea of 48. And there was mild metabolic acidosis with slightly elevated lactate. Otherwise, the liver function tests were all right. There is slight leukocytosis, most likely reactive. In order to evaluate his hypoxia, we got a CT chest done. Just the CT findings. Somebody would like to comment on the CT findings. Forget about what the toxin is. What is the CT showing? Any of the students? Somebody said fibrosis. Who was that? The fibrosis is correct, but I would like to tell me why did you arrive at the conclusion of fibrosis? What are the findings in the CT that led you to consider it's a fibrosis? There are usually 4 characteristic clinical features to identify fibrosis in the CT lung. Some of them we find here, that is the traction bronchiectasis that you can observe here, and there is interseptal thickening. Honeycombing also is another characteristic feature of fibrosis, not very prominent here. So here we have traction bronchiectasis and interseptal thickening, most likely looking like fibrosis, and probably the fibrosis is the cause of his hypoxia. So, to summarize, a young male, 3 to 4 weeks of progressive disease with oral ulceration, acute kidney injury, delayed respiratory involvement characterized by pulmonary fibrosis, and some of the investigations that we saw with deranged renal function tests. What could this possible poison be? He ingested something 3 weeks back. Obviously, he didn't reveal it initially to his parents. Later, since the discomfort was increasing, the parents brought him to the medical attention. So it's 3 weeks over. Nobody has any clue of what he took. He is not revealing anything about what he took. Based on all this, very right, very right. Why do you feel it is paraquat? Yeah. Hypoxia could be due to aspiration also.
Sir, there are CT changes also, sir.
Okay.
Lung fibrosis.
Okay. So some of the overzealous doctors actually started him on oxygen therapy, and he worsened rapidly. Any idea why he would worsen after starting oxygen?
Free radicals will cause the further damage.
So paraquat, as all of you rightly said, it's a commonly used herbicide ingested for suicidal intentions. Its main pathophysiology is by generation of free radicals. And by administering oxygen, we tend to worsen the free radical injury, thereby clinically they worsen. But clinically, you have to still confirm the diagnosis. This is just a hunch, a clinical, contextual, circumstantial evidence. Is there any test to confirm that it is paraquat? Can you identify paraquat somewhere in the body? Very rightly said. I appreciate that. So this is a urine diethionide test. It's a very simple test. Collect 10 ml of urine, add it to sodium urine diethionate, and if it converts into blue, greenish blue color, then that indicates presence of paraquat in the urine. So in scenarios where you don't have any other evidence, the patient is non-revealing, and your suspicion is very strong, and you want to confirm, this test is very valuable. So the main mechanism of injury is by absorption into the lungs and kidney, and this absorption occurs very fast. In less than 2 hours, the paraquat is taken up by the type 2 pneumocytes within the lung. So whatever intervention we have, you only have 6 hours to actually intervene if we can alter the course of the patient. Some of the recently used methods are charcoal hemoperfusion, and some of the recent trials have shown that charcoal hemoperfusion is actually altering the course of these patients who would otherwise have a fatal outcome. And this also, if instituted within the first 4 to 6 hours, has a benefit in definitely preventing the kidney injury. Whether it can prevent long-term pulmonary fibrosis, we are not sure yet. And the other contention issue in paraquat poisoning is at what point do you start oxygen therapy? Because starting oxygen therapy is maybe counterproductive. So you wait till there are signs of hypoxic organ damage, and then you start oxygen therapy, and then you titrate it to the least level possible in order to minimize the damage. And patients who are coming with multi-organ failure without wasting much resources should be taken for palliative care. Second patient, an 83-year-old retired biochemistry professor. He was found unresponsive by his wife in his bathtub. And when the paramedics arrived, he was hypopneic with a barely palpable pulse and no BP. His medical history was significant for ischemic cardiomyopathy and a recent stroke. And upon arrival at the hospital, he had a weak pulse, no measurable BP. There were no significant respiration, so he was immediately intubated. He was hypothermic with mydriatic pupils. The mucosa was pink, there was no signs of trauma, and he was started on IV fluids and vasopressors for hemodynamic stabilization. Some of the common immediate investigations that we did were significant for mild hypokalemia. There was significant acidosis with acute kidney injury, and the lactate levels were 6.3. There was metabolic acidosis. Since the pulse was not palpable, all the samples done were venous samples. This was a chest X-ray. Any comments on the chest X-ray? Looking like a pulmonary edema picture with perihilar congestion, and the 2D echo also showed global hypokinesia with moderate LV dysfunction. So he was later shifted to the ICU. He was stabilized with vasopressors. His BP picked up, urine also improved, but his acidosis was persisting. His lactates are 9.7, in fact worsening. Despite improvement of hemodynamics and all the fluids and vasopressors, his lactate was still worsening. So later when the wife came to the ICU, though we were counseling that the patient was relatively sick, she felt he was looking pretty okay, he was looking very pink, looking fresh, and she also handed us a bottle which she found in the bathroom. There was no label on the bottle was empty. So the clues only we had were an empty bottle given the wife, pushing us to suspicion of some poisoning. He had a high venous hypoxia with facial flushing and bright red blood, mydriasis with cardiovascular instability and lactic acidosis. Very good. Cyanide. Is there any other poisoning that can closely resemble cyanide poisoning?
And why did you say it is cyanide poisoning?
Venous hyperoxia and persistent lactic acidosis despite the resuscitation, and altered mentation.
Why is there venous hyperoxia in cyanide poisoning?
At the cellular level,
What kind of hypoxia it is?
it is histotoxic hypoxia.
What do you mean by histotoxic hypoxia? Unable to extract. So the oxygen remains in the system, but it is not used for the cellular function.
The cyanide binds in the ferrous form in the cytochrome oxidase, which does not allow it to be released into the circulation, causing histotoxic. Yes, sir. So any other poisoning that can closely resemble cyanide poisoning by showing venous hyperoxia, flushed extremities?
Carbon monoxide poisoning.
Okay, how do we differentiate clinically?
Usually, carbon monoxide will improve with the oxygenation, sir.
Okay.
Once the patient has been put on the ventilator.
What kind of oxygenation? Simple oxygenation or any special kind of oxygenation?
Hyperbaric oxygen, it takes less time. Within half an hour, the patient will be fine. And lactic acidosis, there also it persists.
It is there. Lactic acidosis is seen in both, but the lactates are much worse in cyanide poisoning.
Yes.
And the other confirmatory test is the coaximetry. In coaximetry, you can get to know the carboxyhemoglobin levels. Yes. That is a clear-cut finding. Third patient, a 25-year-old male from Nalgonda, previously healthy with no comorbid conditions, presented with the alleged accidental consumption of a small quantity of colorless water which was stored in a Mazda bottle. He was thirsty, so he thought it was water, he consumed it. And immediately following consumption, he developed throat pain with difficulty talking. He had mild upper abdominal pain, but no obvious respiratory distress. So he was immediately rushed to an outside center. He was initially stabilized. A routine CT scan of the abdomen was done because he was complaining of pain abdomen, and then referred to our place 24 hours later. On arrival, the patient was conscious, alert, not in obvious distress, but he was clearly dysphonic and dysphagic. The uvula was edematous. Vitals were stable, oxygenation was all right, abdomen was soft. This was the chest X-ray. An erect abdomen of the X-ray. And a CT abdomen that was done outside. I would like some inputs on the CT abdomen here. Do you find any abnormality in the first place? And what is the probable abnormality? Pneumobilia. Who commented pneumobilia? Pneumobilia. How can you say it is pneumobilia and not air? We are saying pneumobilia, air in the biliary tract. So whenever there is air in the liver, it could either be in the biliary tract or it could be in the portal venous channels as well. So how do you say this is pneumobilia and not air within the portal venous system? So there are very slight clues to differentiate that. So biliary tracts are usually central. So air within the biliary tract, the deposits are usually central and they are more dilated. Whereas portal venous channels are more distributed to the periphery and branching type. So air within the portal venous system is usually more concentrated in the peripheries and appears to be branching, if you can see here. So this is more of a picture of air in the portal venous system, but I agree that it may be very hard to differentiate which one is which. Sir. Yes, sir. So as sir rightly said, the blood investigations were all normal. So we wanted to check what was the significant abnormality and we repeated a contrast CT. So that would differentiate between a pneumobilia and a portal venous gas. This was the contrast CT abdomen that was done. Can anybody tell me the abnormality on this CT? Or actually the lack of abnormality on this CT? The air pockets which were initially visualized in the CT that was done outside is not there now. The liver looks pretty much normal. And we also did some chest cuts. In the chest cuts also pretty much okay, but you can see slight pockets of air in the esophageal wall. Otherwise it was normal. An endoscopy was also performed subsequently, which showed grade 2A and esophageal and grade 2 gastric erosions. Subsequently, the patient was stabilized, he was started on liquids, he became better, he even got discharged uneventfully. My question is, what was that colorless liquid that he took? Sorry? Formaldehyde. No. Sorry? Kerosene. How would kerosene explain or formaldehyde explain these reactions?
Sulfuric acid.
It is some liquid. The main path. Sorry, somebody is talking. Somebody was talking.
Acid injection, sulfuric acid.
Sulfuric acid. It's a possibility. So it is some compound that when ingested and comes in contact with hydrochloric acid in the stomach creates a effervescent reaction. And in that effervescent reaction, air or oxygen is released at high pressure. And under high pressure, the air can disperse into the surrounding tissues, most commonly the liver. It can go into the IVC. It can go into any of the arterial system as well. In this scenario, what he ingested was hydrogen peroxide. So hydrogen peroxide, when he consumed, he took it, an effervescent reaction was produced, oxygen at high pressure dispersed into the liver, dispersed into the veins. Luckily for this chap, there were no events. Otherwise, air in the portal venous system can lead to fulminant hepatic failure and can be life-threatening as well. As I was talking before, some of the features in which this can be differentiated. What other scenarios can you find pneumobilia? Forget this patient. In a regular routine hospital stay, what are the other scenarios where you might find a patient having pneumobilia?
Sai Kiran.
Sir.
Usually, if it is a corrosive injection,
yes.
They will have perforation
yes.
Before going for any air in the or outside the esophagus.
Yes.
So this will not fit into a patient of corrosive injections.
Yes, sir.
Because we didn't see any air in the liver system or portal venous system in corrosives unless
yes,
there is a perforation and significant periesophageal
right,
air.
Right.
So this is not a differential diagnosis for a corrosive.
Corrosive.
Kerosene also, you'll see extension pneumonitis.
Pneumonitis.
And even here, why one point against corrosive poisoning is corrosive poisoning, you'll see definitely some GI injury.
Yes.
Here endoscopy
Yes,
is
there should be
almost
perforation for the air to embolize. Right.
So
Yes,
and
that's also true.
And your history says it's a clear liquid.
Yes.
Kerosene is not
Yeah,
a clear
that was
liquid.
another clear colorless
Kerosene is not
liquid.
a clear liquid.
Yes, very right. Coming back to my question, any other common scenarios where you would see pneumobilia or air in the portal venous system? Right, mesenteric ischemia causing bowel gangrene can cause. Any other iatrogenic causes? I would like our gastroenterologist to comment.
ERCP.
Right, right, sir. Sometimes post-procedure also, post-ERCP, there can be air pockets seen within the...
in portal vein, no.
Okay, in the pneumobilia.
Pneumobilia
Yes.
only.
Next patient, sir. Yes, well, out of the 9 scenarios that I'm presenting, about 3-4 are taken scenarios taken from elsewhere, from journals, and trying to make it interesting. But this was one case which I actually saw during my residency days, and the images also are real images of the patient taken with permission, of course. Yeah, though it looks relatively rare, but I saw it, so definitely it can come again. Next patient is a 25-year-old male apiculturist, no previous comorbids. He presented to the ER with retrosternal chest pain, diaphoresis and flushing, tachycardia with hypotension, and an erythematous maculopapular rash. He was otherwise asymptomatic 4 hours back when he left to work in his farm. This was the ECG on arrival. I would like somebody to please comment on the ECG findings. Sorry? One person, please. Pericarditis. How did you arrive at that conclusion? Any findings to support pericarditis on the ECG? Right. There are significant ST elevations in 2-3 AVF and the anterior leads. There are some ectopics. So, looked more like an acute coronary syndrome. We did some relevant lab investigations. The counts were elevated. The tropi was positive. A pro-BNP was also elevated. So we most likely suspected acute coronary syndrome, and he was taken up for an immediate angiogram. But surprisingly enough, the angiogram turned out to be normal. The coronaries were normal. He was actually a 28-year-old male. You would not suspect an ACS in a 25-year-old male. The coronaries were normal. There were no plaques or erosions. And an hour and a half passed by before all this happened. And an ECG repeated within an hour and a half was like this. What are the findings now? The significant ST changes have normalized. There are no clear-cut ischemic changes. There are no ectopics. Looking like resolution of the ischemia, whatever may have caused the ischemia. So what could have happened here that triggered a transient ischemic attack in this patient, which later normalized? Coronary spasm, correct. Secondary to what? Any presenting history, his context that may tell you what caused the coronary vasospasm? I tell you, he had a maculopapular rash, he was diaphoretic, he was in shock. Does ACS cause a maculopapular rash routinely? Somebody, I think, murmured the right answer. Bee sting. So he was an apiculturist, that is a beekeeper. He was working in his farm and he was suddenly bitten by a bout of bees. And that triggered an anaphylactic reaction, leading to an anaphylactic shock. And that anaphylactic reaction also triggered a coronary vasospasm, which is known as Cownie's syndrome, also known as allergic angina syndrome. That is an anaphylactic reaction triggering coronary vasospasm, which resembles an acute coronary syndrome, but in fact with normal coronaries. This is one of the common causes of an entity known as MINOCA, that is myocardial ischemia with non-obstructive coronary arteries. There can be many other causes, coronary and non-coronary. An allergic or an anaphylactic reaction is one cause which can occur. Next patient, a 56-year-old male, diabetic, CKD on dialysis, presenting with fever, cough and expectoration, mild hypoxia, needing oxygen of 3 liters per minute. Lost his wife recently, lives alone. He was on metformin and insulin for diabetes, multivitamins and escitalopram. This was the X-ray. Any comments on the X-ray? Any others? I see the same students answering again and again. I would like more participation from those in the back. Wedge-shaped opacity. Okay. Suggesting? Sorry? I didn't get you. Looks more like lower lobe, but okay. Aspiration, possible. So it was something like a lobar pneumonia, where aspiration or more likely infective. So we thought of infective, so blood investigations also supporting the same. There was neutrophilic leukocytosis. Creatinine was 2.3, but he was a CKD on dialysis patient. And the CRP also markedly elevated, 136. So we thought pneumonia. Since he was on dialysis with hospital visits, suspected hospital-acquired pneumonia, he was started on empirical antibiotics, cefpozosin, sulbactam, and linezolid, along with other supportive care, that is oxygen, mucolytics, and nebulizations. 48 hours later, his lungs seemed to improve. He was off oxygen therapy, but he seemed to become increasingly agitated, disoriented. He was spiking very high fever at 105 with shivering, multiple episodes of loose stools with neck stiffness and clonus. This was 48 hours later when actually the lungs seemed to improve, but the patient seemed to worsen with high fever and loose stools. So he was increasingly irritable, not cooperative for treatment. We had to do an imaging of the brain. So we put him on the ventilator, performed on MRI, which was insignificant, did not show any meningitis kind of changes. There were only small vessel ischemia. And LP was done, which revealed only 2 cells. Proteins were normal, sugars were normal. So what went wrong? What is going wrong with this patient who seemed to be improving for a community-acquired or an hospital-acquired pneumonia, but worsened 2 days later?
Serotonin syndrome.
Right, who's that? Sorry? Yeah, why did you suspect serotonin syndrome?
Patient on escitalopram.
Okay, he was on escitalopram for a long time. Why now?
Yeah,
CKD
exacerbated
has
with
been there for a long time. Why now? What is serotonin syndrome?
Exacerbated during stressful conditions.
Sorry?
During stressful conditions.
During stressful conditions, you get serotonin syndrome. May not be. He is on an SSRI. He is taking escitalopram. He's been taking it for a while now. Why did the serotonin syndrome trigger now? Anybody? Linezolid. Right. So serotonin syndrome basically occurs when a patient already on a serotonin agonist takes another medication which also increases the release of serotonin, and then there is overactivation of the serotonin receptors triggering a serotonin syndrome. And here in this patient we see the classical symptoms of a serotonin syndrome. So by reviewing the history, we looked at his drug history again. We noted again, which we missed before, that he was on escitalopram. Then we discontinued the linezolid. We de-escalated the antibiotics. He improved, extubated, and shifted out. So there is one clear flowchart to diagnose serotonin syndrome, that is the Hunter's criteria, which is as this, that is the patient who's on a serotonergic agent presenting with spontaneous clonus or inducible clonus with hyperreflexia and tremor, most likely goes in favor of serotonin syndrome. And the only treatment needed is the withdrawal of the offending drug. There are 2 other conditions that can mimic serotonin syndrome or similar to the hyperpyrexic syndromes that we routinely see in ICU. What are the other 2? One is the neuroleptic malignant syndrome and malignant hyperthermia, which are the other 2 hyperpyrexic syndromes that we commonly encounter in the ICU. Neuroleptic malignant syndrome is most commonly due to prolonged exposure to dopamine agonists, whereas malignant hyperthermia is after administration of inhalation and anesthetics. These 2 can be differentiated definitely based on contextual situation. Next patient, a 24-year-old female student found by a roommate in a drowsy state, On examination, she looked very skinny, lethargic, poorly responsive to commands with pain in the right upper quadrant region. Airway was clear, vitals were stable. And we were suspecting some overdose. So we did a urine toxicology that was negative for benzodiazepines. Blood alcohol levels were undetectable. Imaging of the brain and EEG were normal. And the roommate revealed that she had recently been started on some medications for fever. These were the routine lab investigations. What are the abnormalities that you find here? I've pointed it out already, but which one? Yes. Yes. We have some very highly intelligent CIDs here today. I think they have a great prospect in the future. So this is a young female, apparently malnourished, with acute hepatitis, coagulopathy, and acute kidney injury, with a roommate giving history that she was started on some drugs. So more of a drug-induced hepatitis. And it could be many other causes. Why did you only come at acetaminophen? Okay. Very nice, sir. So, but for the same acute hepatitis kind of picture, can we have some other differentials? May not be applicable in this case, but you can't directly come at acetaminophen sometimes. You have to beat around the bush. What could the other possibilities be for this kind of an LFT? Metabolic acidosis causing the okay, fine. For this hepatitis picture, you see, as medicine, it is more of a work of differentials. Arrive at a diagnosis, but don't stop thinking about another diagnosis. What are the possible for a liver? How commonly do you see an enzyme transaminitis in the range of thousands? There are only 2-3 probably scenarios that can cause an transaminitis of that range. Sorry? Hepatitis B. Chronic hepatitis B?
Mahesh?
Acute hepatitis B causing such transaminitis? Viral hepatitis. Any viral hepatitis? Not in 2 days, probably in the second week probably. Okay. Any other more common things that we see in the ICU causing such deranged LFTs in the ICU? Right, ischemic hepatitis usually causes such highly elevated transaminitis. But the point here is he was now never in hypotension. Any other causes, sir? Yeah, in ischemic hepatitis.
Yeah, there is a difference. Here, SGOT is much lesser than SGPT.
Yes.
So, what are the causes of SGOT, SGPT in thousands, and the difference between SGOT and SGPT? So, this scenario where SGOT is greater than, less than SGPT, SGPT is more, then there is more liver involvement or proper liver dysfunction causing this. If you are having a SGOT greater than SGPT, like already ischemic hepatitis,
yes,
or any drug-induced other than paracetamol, where direct liver involvement is there, like anti-tubercular drugs, though they won't go to thousands. Usually, SGPT is secreted by liver only.
Yes.
But SGOT is secreted by most of the other cells like RBCs, brain, muscle. So, any patient involving the systemic disease,
yes,
with the involvement of the liver, then they can have SGOT greater than SGPT.
Yes.
So,
right,
that is where SGPT is greater than SGOT. Here the patient has direct liver involvement,
yes,
than the systemic involvement.
Right.
And the second thing, you need to say, if it is hepatitis B, then you should say it is reactivation of the hepatitis B.
Mm.
Hepatitis B should not cause this scenario unless it is reactivated or acute hepatitis B.
And another scenario, sir, congestive hepatitis, bad heart failure, cardiogenic shock, congestive hepatitis. Is it similar to ischemic hepatitis, or is there any something?
Because in heart failure also there are multiple organ involvement, including liver.
Yes.
So there is ischemia of the other organs like muscle involvement or heart involvement. So SGOT is greater than SGPT. Yes. Any patient in ICU with high or thousands, there are 4 differential diagnoses for any patient with SGOT, SGPT in thousands. Viral hepatitis, where you see SGPT is greater than SGOT. Other scenarios, acute obstruction of the stone, but it is very rare, but it also is causes into thousands.
Acute obstruction of the
biliary duct.
But ALP would be elevated in such scenarios.
ALP and GGT is also elevated in that scenarios.
Yes.
Next, drug-induced and ischemic hepatitis.
Yes.
To differentiate, SGPT is greater than SGOT in viral hepatitis.
Yes, sir. Right. So we did this in, sorry, yes sir.
Actually, history-wise, she has a fever.
Yeah.
So we have to think for differentials of fever also.
Fever.
So any AKI with hepatitis.
Fever, AKI, hepatitis.
As you routinely see, C for malaria, C for leptospira, C for scrub typhus.
Absolutely.
These are the differential diagnosis. Which
Tropical fevers need to be excluded.
Need to be excluded also.
This 2-3 years, previously dengue we can see the SGOT, SGPT into 200s and 300s. These 2-3 years where rampant dengue is there, now we are seeing into thousands. So this scenario can fit into dengue also.
Viral
Need to rule out because that is more common than an acetaminophen in
Any
India.
specific reason for the change in these last 2-3 years?
No, don't know.
Probably they are getting more treated outside in the peripheries and then coming late to us. Yes, and even within the same patient, a second attack is more severe compared to the first one. Yes, yes. So as acetaminophen levels were clearly elevated in this patient, we started her on acetaminophen drip and other supportive care, and FFPs are to be avoided unless there is active bleeding, irrespective of the INR. Don't treat the INR, treat the patient clinically, and a liver transplant team referral is warranted at an early stage so that they can move on as early as possible. Another point I would like to make about acetaminophen is most of you, for academic purposes, would have seen this chart. What is this chart? It's a Rumac-Matthew nomogram, but we don't routinely use it because it's more applicable in the first 24 hours of the poisoning, and usually we do not have serum acetaminophen levels available within that time. But just for academic purpose, this is the line, and any value to the right of this line needs to be treated, while any value to the left of this needs to be closely observed. And that line is drawn at 150, and it varies based on the country. US 100 mg per liter is followed, in the UK 150. So whichever is country specific. Values to the right of this nomogram have to be treated, whereas to the left have to be observed. Next patient, a 16-year-old male presenting with abdominal pain for 3 months, lethargic behavior for 1 week, and a new onset GTCS episode 1 day back. The patient is a known sickle cell disease but otherwise stable, not needing any transfusions or admissions in the last 3 years. On examination, the patient was drowsy, arousable, obeying simple commands. There was mild pallor, no injection marks, bruises or petechiae. Vitals were okay, but the only significant thing is that BP was on the higher side, hypertension. Chest was clear, abdomen is soft, but there was diffuse tenderness and bowel sounds were sluggish. We done the repeat blood investigations, and those were significant for microcytic hypochromic anemia, slightly elevated blood urea, LFTs were all right, and the iron levels were also low. This was the peripheral smear of the same patient with microcytic hypochromic anemia. Can anybody tell me what these cells are? Sir? Any students who can comment on what this peripheral smear is showing? So you can see red blood cells, but there are few red blood cells with granules, with basophilic granules in the RBCs. This pattern is usually called basophilic stippling, where there is basophilic staining in the RBCs within the cytoplasm. The attenders also, when we were inquiring the history further, the attendant was saying that he was also complaining of joint pains. And an X-ray was done about a week earlier to evaluate his joint pains. And he just handed us the X-ray as well, just so that it may give us any more information. This was the X-ray. Does anybody find any abnormality on this X-ray? And if you notice keenly, the metaphyses appear to be very dense calcification. There are very dense metaphyses which are not expected at the age of 16 years. So, this patient, young boy, non-sickle cell disease, presenting with chronic abdominal pain, involvement of GI and nervous system with microcytic hypochromic anemia, basophilic stippling, and dense metaphyses on long bones. There is no more information to come at this conclusion.
Lead poisoning.
Very right. Who was that? Good, good, good. So, why would he have lead poisoning? Any guess? I'm saying he has iron deficiency anemia. Can iron deficiency anemia cause him to have lead poisoning? Absolutely right, sir. So he was living in an old house with lead paints. The lead paint was chipping away. So because of his spica, he used to ingest those chips of lead paint, and over months to years, he landed up in severe lead poisoning. So treatment is mainly decontamination, and when the blood level concentrations are very high, you need to chelate either with dimercaprol, that is British anti-leucide, Succimer DMSA, or calcium meditate. And if the hematocrit is less than 30 or severe anemia, blood transfusions are also needed, because anemia in itself predisposes to increased lead absorption from the GIT. If the hemoglobin levels are good, it decreases the absorption of blood from the GI tract. Next patient, a 28-year-old male who was found unresponsive at the airport. On examination, he was drowsy, not obeying with mild neck rigidity. His pupils were 0.5 mm with sluggish reaction. Limbs were with normal tone reflexes. On vitals, he was having fever, 100, mild hypoxia, 88% saturation, in shock state. The abdomen was tense, distended, and bowel sounds were absent. Some basic blood investigations were done. It was significant for leukocytosis, acute kidney injury, raised urea, severe metabolic acidosis, lactate 15, mild transaminitis, and sugars were also slightly on the lower side. Since his abdomen was too tense, we were suspecting some intra-abdominal pathology, and we got an imaging of the CT done. Anybody? A Tamil movies fan should be able to guess this. Sorry? What do you see in the abdomen? Okay, diagnosis later. What are you seeing in the abdomen?
Cocaine packets.
Cocaine, pellets of cocaine. That is one innovative way of smuggling drugs across. So what they do is they pack cocaine or heroin or whatever in small capsules. They ingest those capsules and transport it across. But unfortunately for this chap, one of the capsules perforated. That led to systemic release of the toxin. It was heroin. It led to systemic release. And it was too late for this chap because he landed up in multi-organ failure and succumbed to his. But in any scenarios where you're coming across opiate toxicity in a reversible state, naloxone is the usual antidote administered to reverse the respiratory depression, along with other supportive care. Ninth patient, a 28-year-old male with a history of depression. He was found unresponsive and breathing rapidly in a park. When the paramedics arrived, he was tachypnic, holding other vitals. He was in sinus rhythm, blood sugars were normal. Suspecting some overdose, he was given 2 mg of naloxone, but there was no response. There were no empty pill bottles or chemicals aside. When he arrived at the hospital, his blood pressure was 120 or 80, heart rate, vitals were okay, saturation 100% on 10 liters. There are a few aberrations noted. Since the patient was in poor GCS, he was intubated. CT scan imaging of the brain was normal, and ECG showed sinus rhythm. 2D echo was normal. Blood investigations were like this. What you can note significant is the bad metabolic acidosis with a pH of 6.9. Lactates are elevated. Sodium is on the higher, potassium is on the higher side. Calcium is low. LFT looking otherwise okay. So we suspected some toxicity. Acetaminophen levels were normal. Salicylate levels were normal. Urine toxicology was positive for benzodiazepines, but that was most likely due to the drugs given during intubation. His ethanol levels were also in the non-toxic range. How would you proceed next for this patient? He was found unresponsive in a park. The usual toxins, paracetamol, salicylate, ethanol, all are negative. The only findings you have are severe metabolic acidosis. What kind of acidosis is this? You have a very tedious ABG lecture coming next, but just to give you a brief, what kind of acidosis is this? You have high anion gap metabolic acidosis here. So you are suspecting a toxic agent. There is high anion gap metabolic acidosis. What should be your next step to get better idea? Osmolar gap, rightly, sir. So in a patient with high anion gap metabolic acidosis where the diagnosis is unclear, osmolar gap gives us a good idea of what could the possible be. What is osmolar gap? Sorry? Louder. Yes. So, the usual osmolar gap is in the range of 5 to 10. In this patient, the osmolar gap was 93. So, here we have a patient with high anion gap acidosis and a high osmolar gap as well. There are only a handful of such causes. Further clues. We did a microscopy of the urine. Any comment on what you're seeing on the microscopy? These are crystals. These are calcium oxalate crystals. We further investigated. We brought a Woods lamp. What's a Woods lamp? It's a lamp that generates UV light. And we observed his urine under a Woods lamp. And it was like this. Does the urine appear normal under Woods lamp? Does normal urine appear like that under Woods lamp? The urine is showing fluorescence under Woods lamp, under UV light. So, putting all things together, a comatose patient with high anion gap acidosis, with a raised osmolar gap, calcium oxalate crystals in the urine, fluorescence of urine under Woods lamp. With all this, there can only be one poisoning. Sorry? Antifreeze. What chemical name, sir? Ethylene glycol poisoning. So this patient took ethylene glycol. He was a mechanic by profession, so he had easy access to ethylene glycol. It's an antifreeze used in radiators. So his blood alcohol levels were in the range, ethylene glycol levels were in the range of 888. When ethylene glycol is consumed, it is metabolized in the body by alcohol dehydrogenase into glycoaldehyde and glycolic acid. Glycolic acid is the toxic agent that worsens and creates a storm within the body. So the usual antidotes are agents that can compete with alcohol dehydrogenase and limit the metabolism of ethylene glycol. And the usual agents are fomepizole, but if you don't have immediate access to fomepizole, you can as well administer ethanol itself as a competitive inhibitor of aldehyde dehydrogenase, apart from the supportive care that includes thiamine and pyridoxine. There are few gaps in assessing any toxicological patient where you're suspecting a possible toxin. You have to be aware of 3 gaps. One is the anion gap, the other is the osmolar gap, and the next is the saturation gap. Osmolar gap, as she rightly said, is the difference between the measured and the calculated osmolality. What is the formula for calculated osmolality? Ethylene glycol. Why would ethylene glycol come in calculating osmolality? So you can have a look here. The calculated osmolality is by 2 into sodium plus urea nitrogen by 2.8 by glucose by 18. So there are only, as I said before, osmolar gap with a normal anion gap. You have ethyl alcohol, isopropyl alcohol, glycine, hyperlipidemia and hyperproteinemia. High osmolar gap with a high anion gap, only 4 causes: propylene, ethylene glycol, methanol, ketoacidosis and lactic acidosis. The other point to note is the measured osmolality. Most of the times when we send serum osmolality values to the lab, about 5 out of 10 times you may get the calculated value only back, because not all hospitals have the machine that is needed to measure the measured osmolality. So you have to check with your hospital whether they are just giving you back the calculated osmolality value or they are actually measuring the serum osmolality. Saturation gap, my colleagues would discuss it better in the coming slides. I thank Dr. Shashidhar sir and Dr. Ravi Shankar sir for their valuable inputs. We come to the end of the first half of toxicology, and there is another end that's waiting for you.
Nice presentation, Dr. Sai. Before toxicology becomes toxic, we'll have a tea break and we'll have a lamp lighting ceremony. I request.
Anything you'd like to add, sir? Shashidhar sir has seen a lot of paraquat poisonings of late.
Sir, though there is no outcome in paraquat, I think we have seen 3-4 cases in which we interacted. This intervention was done too early by early dialyzing and further monitoring the patient and avoiding the oxygen, we have referred 2 patients for lung transplant, but one patient was old psychiatry patient, so he never turned up. So, but he was a very young patient, very much fit. He was even fit for lung transplantation also. He improved. And other one was a young female, but they were not affordable. But both of them recovered, but we don't know what is the right now situation. This was 1.5 years back.
So Dr. Sir, anything on charcoal hemoperfusion? We have been doing it off late. I think 3-4 patients we did.
I think we have been doing it probably, but the time is a big factor. Even after coming to ER, it takes at least 4 hours here to arrange for things because of the clearance and other things. I think you also know the administrative things. But probably there should be a scenario where we can dialyze or use a dialysis machine in ER itself. That will save a lot of lives.
Within 2 hours.
Within 2 hours.
Within 2 hours.
Sir, usually for 4 to 6 hours is the ideal scenario. Beyond that, there is no good evidence to support repeating a hemoperfusion, sir. First 4 to 6 hours, first cycle until the filter lasts. That is what we are doing.
Like for charcoal hemoperfusion, let's say it is a hemoperfusion, the porosity or whatever the surface will get adsorbed by the poison. So they suggest 1 to 2 hours is the time frame within which it will get saturated. There are theories like you use one hemoperfusion cartridge, let's say a charcoal, and repeat one more in 3 to 4 hours, and maybe repeat one more after 12 to 24 hours. Have you done that any time?
No, sir. We have been doing it only for the first 4 hours, and then very rarely we have seen if the quantity has been very large, we have repeated one more.
The problem here is we don't do the like levels of paraquat, blood levels, which would have decided us to continue one more. Have you used any other like filters, like hemoperfusion cartridge other than this charcoal?
No, sir, we haven't used.
Actually, I don't know whether the data has been published, but there is one center in Guntur, sir. It was run by a nephrologist. They have seen a significant people, almost 7 to 8 people have recovered completely by early charcoal perfusion.
No, we had 3 cases recovered, sir, where we have done little early. Unfortunately, the people who are coming, they are late only.
Taking those survivals should be taken with a lot of information, sir. We have seen around 9 patients who recovered. But most of them had presented to the hospital early, received a hemoperfusion. The other is the quantity of the toxin. That decides a use. If a patient already in liver failure, renal failure with lung involvement, hypoxia, it is 100% mortality, whatever you may do. So the survivability which we have seen with only renal injury who actually were on dialysis, never been into liver failure or lung failure recovered. And those 7-8 patients are still keep on coming. So it is on the amount of toxin which we say. The another important information I wanted to carry, you have seen CT which is presented by Sidh. Okay, it looks like a destructive fibrotic lung with sometimes a pneumomediastinum or surgical emphysema. In the recent last 2 years, what is the common differential for that kind of lung? COVID. The post-COVID destructive lung will look similar. Okay, if you have a patient who has been referred to you or to me saying it is a post-COVID lung and don't get any clue. The patient says, I never have had any COVID and had a surgical emphysema or a pneumomediastinum, and you see there is a corrosive injury to the oral cavity, keep a suspicion of paraquat poisoning. It happened to us. It happened to us by getting a referral for a COVID or a post-COVID lung turned to be this. We had another similar situation in the past in our previous organization where a young girl was brought to us with multi-organ failure. No clue of any intoxication. We are seeing one after the other organ getting failed. The patient was absolutely normal for a couple of days with saturating around 98. Slowly it started dropping oxygen levels. Kidneys were absolutely normal for a day or two, started deteriorating. LFT started deranged, then we lost the patient within no time. So these are the cases only we could pick up when the patient said, I have a difficulty in swallowing. And I had a difficulty in even talking. There is a hoarseness of voice. There is a difficulty and there is a lot of pulling of secretions. My respiratory therapist came back and said, she's putting a lot of secretions, sir. So suddenly when we examined the oral cavity and hole throughout the gut, We found all the gut has been eroded with erosive poisoning. When we inquired back, we found a paraquat poisoning at home with an empty bottle. The girl never expressed it. It is a live scenario. So a patient with unexplained organ dysfunction with hypoxemia, LFT derangement and renal derangement may be lying to you, not expressing that. Keep an eye on paraquat in a young individual, no comorbidities, no other illnesses other than your systemic illnesses.
Thank you. Thank you for the inputs. Now I request Dr. K.C. Mishra to hand over a token of appreciation to Dr. Sai. I request Dr. Mishra again to present a token of presentation to Dr. Ravi Shankar Reddy. I request Dr. Bharat Kumar to present a token of appreciation to Dr. Shishidhar Reddy. Now I request all the consultants and critical care team members of all three branches to come forward for the lamp lighting ceremony.
Come, sir. Krishnamon Reds will join. Karthik, Shashidhar, Shankar, Prasad, Ramakrishna, Hari Prasad, Sharan. Please come.
morning, everyone. So there was a talk before which was good by Dr. Sai. So we'll see some normal cases which we see in the ICU regularly now. So case 1, a 58-year-old male with history of AF and systolic heart failure with EF of 35% and is known diabetic and depressive disorder, found unresponsive by his wife, rushed to the ED. The patient was complaining of blurred vision since past few days and the vitals were showing BP was very low and heart rate was 46. Mic, sir? Okay. So this is the ECG, what we have seen in the ER. So can any one of you read the ECG, please? Flutter with? What? Oh. Okay. Okay, one more thing. We're missing. Okay. So then the labs were showing hyperkalemia with normal ABG. Sorry. So what you think is the diagnosis of this patient with the history and the ECG? No, the history, AF and systolic heart failure, and he was complaining of blurring of vision, and there is ECG showing some arrhythmia with block, and there is hyperkalemia. So it's a digoxin toxicity, which the patient has 5 nanomoles per liter. The normal is around 0.5 to 2 nanograms per ml. So usually digoxin acts on sodium potassium ATPase on several areas like cardiac, smooth muscle, skeletal and lungs. So it has also increases the vagal tone and decreases the sympathetic activity. So these are the non-cardiac symptoms which we see: gastrointestinal, neurological and visual manifestations. Mesenteric ischemia is not very common. So cardiac manifestations most commonly we'll see due to increased automaticity, which is due to increase in calcium, and there will be the vagal tone will be increased, so there is a block in AV and sinus node. So based on the case series, so they have seen whenever the patient age is increased and if there is an AV block and hyperkalemia, you can see that the rate can be varying. So green lines were showing less, probably the rate is less, and red line which might increase whenever they see the age is more than 55 and AV block and potassium is more than 4.5, the death rate increases up to 74%, which this patient is fit for this thing. So most of the management include gastrointestinal decontamination, extracorporeal removal techniques, and electrolyte abnormalities. Okay, sir. Non-antidotal therapies and anti-digoxin specific fragments. So can anyone say how will we treat hyperkalemia in this patient with ECG changes? Can we give calcium gluconate? Why? Because already myocardium is loaded with calcium. So if you give calcium gluconate, it might worsen the arrhythmias. And one more thing, is the arrhythmias responsive to defibrillation or cardioversion? No. So next case, a 28-year-old male with a history of type 1 diabetes came to the ED with 3 days history of worsening of blurring of vision, difficulty speaking, and progressive dysphagia. He was initially treated as a migraine headache, but this headache has resolved, but the blurring of vision progressed to double vision, And he had difficulty in formulating words, swallowing liquids and solids with change in voice. So no other persons around him were sick, and no other travel or environment exposure. He only positive history is a IV drug abuser, and he has clean for some time. So vitals were normal, a little bit BP was on higher side. On examination, there is a bilateral ptosis with ophthalmoplegia involving cranial nerves 3 and 6, and weak gag reflex and palatal weakness, and there is weakness of upper limb more than lower limbs with diminished reflexes. So laboratory values and ABG looks normal, MRI was normal, CSF analysis was normal. Only nerve conduction studies were showing diffusely low amplitude of motor action potentials with incremental response in fast RNS. EMG was showing fibrillatory potentials and positive shock waves. So what is the diagnosis? So how can you say it is botulism? Okay. What type of botulism it is? It's a wound botulism because the patient was an IV drug abuser. So as you said, there is a descending paralysis. And the fast RNS was showing incremental response, which shows that is a presynaptic involvement. So how will you diagnose? Most of the times we'll diagnose with the clinical criteria because all the other things which takes time and delay the treatment response. So how will you manage? So we'll manage with heptavalent botulism antitoxin, which composes of A to G, and the dosage has been given. So most of the times it is taken from the horse. So there will have an allergic reaction with this. So case 3. A 26-year-old female brought to the ER with complaints of SOB, headache, chest discomfort, palpitations, or abdominal pain, vomitings of 2 to 3 episodes. She was fine previously before this incident, and her LMP was 1 week back. Her mother was hypertensive on medication. When she brought to the ER, she is tachycardic with hypotensive. So all other investigations are normal. ABG was normal in the ER. So she was, except for hypotension, so she was shifted to the ICU. In ICU, after 6 hours, there was a worsening of hypotension, the hyperglycemia, which acidosis was worsening with lactate of 6.4. And it was not responding to any of the vasopressors or fluids. So what might be the cause for this? Which one? Yeah, correct. So how did you conclude it is calcium channel blocker overdose? Okay, then? Okay. Okay. So actually ECG was showing sinus tachycardia, the X-ray was normal. So when we asked the attenders, they brought the amlodipine strips, which was 30 tablets she has consumed. So most of the time, this is the classification of CCBs, where amlodipine, a group, dihydropyridines, will most of the times will not cause brady. They'll mostly cause tachycardia with the peripheral vasodilatation, which is resistant to all the medications. So only treatment is, we'll have to give height therapy and also calcium supplementation, and if it is resistant to all of things, we have to go for the intralipid. So this is the flowchart which is showing the calcium channel block toxicity management. So initially we will decontaminate the patient, observe for the symptoms. If she is not any symptoms, just observation. Then we will go for if she is having hemodynamic instability, then fluids, then calcium supplementation, high insulin therapy. If there is a bradycardia, we'll go for pacemaker or lipid emulsion therapy. Myocardial dysfunction, we'll go for incremental height, increasing the insulin up to 10 units per hour. And kg per hour and lipid emulsion. So if the patient arrests, then we'll go for the ACLS protocol. So fourth case, a 50-year-old male with came to the emergency department with SOB, chest pain, pre-syncopal episodes, increased lethargy, weakness, pallor, and occasional blue hue to his hands. He is known history of hypertension and SLE on prednisolone, methotrexate, dapsone, and hydroxychloroquine. So when he came to the AR, the vitals were showing there's hypoxia, which SpO2 was showing 85, and ABG was showing severe metabolic acidosis with PaO2 230, 213. So all other parameters were normal. So what do you think is the patient consumed, or is the toxicity? So how did you conclude that it is methemoglobinemia? Yeah, very good.
So there is a saturation gap. There is a confounding factor which can create a methemoglobinemia.
So this is, what is this test? Can anyone say? Which one? Yeah, what is the color of the blood? So chocolate brown color, most commonly when we place the blood, deoxy blood in a filter, it will turn red, but in methemoglobinemia, it will be like that only. So chest X-ray was normal, and the co-oximetry was showing methemoglobin was 39.3%. So these are the levels where we can see the symptoms for the patient, different symptoms, and which depends on the levels of the methemoglobin. So in this case, the drug is dapsone. The other drugs which can cause is local anesthetics, aniline dyes, benzene derivatives, and nitrates, along with metoclopramide. So this is how this patient will have oxidized hemoglobin. This is the where the reaction which occurs inside the body. So treatment wise, can anyone say the treatment? So when the patient is asymptomatic, give oxygen, monitor hemolysis, and monitor severe methemoglobin levels. Symptomatic patients will give methylene blue, blood transfusions, and exchange transfusions. So are there any conditions where methemoglobin, methylene blue is contraindicated or cannot be given? Any other thing? Can we give in pregnancy? Why? Okay, so this is class X drug which is harmful to the baby. And NADH, pH, oxidase deficiency also you cannot give. And also when the patient is on SSRIs, antidepressants, if you give, then it might cause serotonin syndrome. So case 5. So 44-year-old male with chief complaints of nausea, vomitings, diarrhea, agitation, and fascicular twitching with confusion, associated with confusion. His history of recreational drug abuse with suicidal behavior. He was diagnosed with bipolar affective disorder on medication. He denies any substance ingestion. So when he came, BP was on lower side, other vitals were normal. On examination, he was little drowsy with hypertonic limbs and brisk reflexes on bilateral lower limbs. The chest was clear, and he was shifted to the ICU where we have for further evaluation and management. In the ICU, what we have found is he having polyuria with 7 liters within 24 hours. So based on the history and findings, can we guess what might be? Yeah, lithium toxicity. How? Okay. No, bipolar affective disorder. Next. Polyuria and? So this is the ECG. Can anyone read this ECG? Yeah, junctional rhythm with bradycardia. So So this is the lab values which was showing hypernatremia, which sodium was 150 and creatinine was 1.8 and ABG looks normal. So his serum concentration of lithium was 5.4, which is very high than normal therapeutic concentration. So most of the times, patient will present with mild intoxication, nausea, vomitings, and diarrhea. Moderate intoxication, they have CNS symptoms and nystagmus, ataxia, confusion, myoclonus. Severe, they might have seizures, coma, and death. So case 6, a 45-year-old farmer, he had vomiting, some abdominal pain associated with SOB, and patient family members brought him to the ER. Before this incident, he was normal. In the ER, the patient had BP of 190 over 100, which and other vitals were normal. On detailed examination, the patient was comatose, pupils were dilated, non-reactive to light, and associated with ophthalmoplegia and pupillary and vestibulo-ocular and corneal reflexes now absent. So on auscultation, he had coarse crepitations bilaterally. Cardiovascular examination was normal. So these are the labs. Can anyone guess what is the poisoning? Or so he is in comatose state with absent brainstem reflexes and some aspiration probably.
So what all those are indicating? Comatose, pupillary dilated, not reacting, no reaction of pupils, no
Before
vestibular
slide, okay.
recursion.
And a little hypertension. Which snake?
Why snake bite and which snake?
Which snake? So, and one more clue is there. So nerve conduction studies showing reduced amplitude with decremental response with RNS. And hydrophenum test was negative.
Why crate?
So this is a crate envenomation where we can see neuromuscular paralysis with minimal local signs, and most of the time it will be absent because patient will be sleeping in the night. The snake bite would have occurred. Morning he would not woke up. So thinks he had a stroke or some neuromuscular paralysis. He will be brought to the ER. There these findings we can see. So you'll have abdominal pain, autonomic dysfunction also the characteristic feature with bulbar involvement. Case 7. A 54-year-old male brought to the hospital with chief complaints of SOB, cough and confusion. He has past medical history of hypertension, diabetic, CAD and obstructive sleep apnea. The vitals were normal. Physical examination was crepitations over the right and lateral anterior chest. So chest X-ray was showing consolidation on the right lower base, and he was initiated on BiPAP because of worsening of hypoxia. So he was later intubated. So blood, urine as routine cultures was taken and started on broad spectrum antibiotics. Day 2 the cultures has come which was showing Streptococcus pneumoniae. So in all the cultures. So he was treated on broad spectrum antibiotics which was continued. Then the lab was showing elevated bilirubin and SGOT, SGPT with raised WBC. So on day 4 the patient had increased temperature, elevated BP, and he was tachycardic, and he was very agitated with flushed skin and was diaphoretic. On CNS examination, there was a rigidity bilaterally, and meningeal signs were absent. So MRI was done, it was normal. EEG was showing there is no epileptic activity, and repeat chest X-ray was showing resolution of right lower lip consolidation. Blood cultures repeated was negative. Can anyone guess what is that? What might have caused the rise in temperature on day 4? The patient was on continuous sedation and ventilator, and he was treated, initially presented with consolidation, which was also resolved.
What was the differentials for such a high-grade fever?
So it is neuroleptic malignant syndrome. So he was treated with haloperidol intermittently. So this picture will give all the clues. So he was with whenever there is patient was on antipsychotics within 2 to 10 days, and lead pipe rigidity with raised temperature, autonomic instability, and altered mental status, which is a tetrad. So whenever you see these signs, you can conclude that it's a neuroleptic malignant syndrome. The differential diagnosis will be serotonin syndrome, which already discussed. So you can suspect when there is a patient is on antipsychotics. So there is some diagnostic criteria which will help you to diagnose. So whenever the patient has exposure to dopamine antagonist or withdrawal within past 3 days, hyperthermia, rigidity, altered mental status, and raised creatinine kinase. So the patient was, the blood test was repeated, there was CPK level of 8,450. So there is, when there is a creatinine kinase elevated, sympathetic system liability and hypermetabolism, negative workup for all the infections, metabolic and neurological causes. So case 8, a 76-year-old male was brought to the hospital with altered mental status and hypoxia. He was very confused and appeared to be hyperventilating. So 4 days back he had fall at home with straining of lower back, and he was on pain medication. So he was feeling nausea, and there was a non-bilious vomitings at house. So his vitals were normal, examination was unremarkable except for delirium. And these are the labs which were showing there is respiratory alkalosis, metabolic acidosis, which with high anion gap and non-anion gap and high anion gap metabolic acidosis, elevated lactate, and metabolic alkalosis. So can you guess what is the cause for this patient symptoms? Yeah, salicylate toxicity. So can anyone say why there is metabolic alkalosis in this patient? Yeah, due to vomitings, he had metabolic alkalosis. So whenever the patient on pain medication with metabolic acidosis and respiratory alkalosis and metabolic acidosis, then we can suspect there is some salicylate toxicity. Most of the times it will stimulate the respiratory center in the brain, which causes increase in respiratory rate, which might lead to respiratory alkalosis. Later on, the patient will develop metabolic acidosis due to loss of bicarbonate from the urine, and also hypokalemia due to loss in the urine. So these are the symptoms which you can see, and also the salicylate will inhibit the glucose metabolism pathways. So where you can see the lactate will be raised. So these are the symptoms which we see in salicylate poisoning. So can anyone say the treatment of this salicylate poisoning? Treatment. Management of salicylate poisoning. So whenever the patient is altered sensorium is there, or this comatose, will intubate him, but be careful with the pH. So increase the rate, maintain a pH of more than 7.5, and we give sodium bicarbonate and potassium, and withdrawal of the drug. And foremost, you will have to decontaminate the patient with gastrointestinal decontamination. Thank you.
coming to digoxin, digoxin is a very toxic drug actually. In the current generation, current practice, majority of people stopped using digoxin. Only advantage with digoxin, maybe it is the only orally available agent which can cause some inotropic activity, which has shown some inotropic benefit. That's why maybe in severe LV dysfunction with dilated chambers, where we want to control the rate, if we use other agents, that will cause, along with the rate control, it may cause the decrease in the contractility also. That is the reason digoxin is still in use. That's can opine actually.
I think for the digoxin, no, the trials, which are not the new ones, in 2006, the biggest trial for digoxin was DigiTrial. They've decreased all the doses, what they used to give before that. You may not be aware of, but we used to give 0.25 daily for 5 by 7 days. Now they've decreased to half of that. In renal failure, even half of that. Apart from that, initially when we used to read in MBBS, digoxin was there in heart failure, any heart failure. Right now, if you ask me, if only one clinical condition where we may think of giving digoxin is AF, LV dysfunction and heart failure. If these combinations are there you can think of give digoxin. Other than that, it is better to avoid digoxin.
And other point is calcium channel blocker toxicity. In that there is a role for even VA ECMO also. Maybe that that was taken from the old this thing, I think. So when nothing is working,
the
flowchart it is there. Okay. So we can use VA ECMO. So that will help. Majority of patients are coming out with VA ECMO. Nowadays we are using VA ECMO rampantly. So that is one thing I wanted to tell. And only toxidrome which was not covered is I think TCA poisoning. The rest all were covered both together. OP and TCA, maybe that we see regularly.
Digoxin we have stopped using it mostly. Right now, digoxin we stopped.
Sure, good morning all. See, wonderful presentation, Prasad. See, what is that, we have to understand from this all together learning is, it is a teamwork. And what is the cornerstone of all success of our management is a proper history taking blood parameters and correlating with the clinical history. So only if we take a proper history from the patients, what is happened, what are the medications patients is prior taking, what are the lab parameters in front of us, and what is the clinical pictures. And only if you put all three in one place, you will be able to do a full justice of patients. And what he has taught to us, and one small example which we'll give, recently we have seen on patients, on elderly patients, diabetic, sepsis, alter sensorium, we were not able, little low on metabolic acidosis, we were not able to understand what was the cause for the alter sensorium. Neurologically all fine, EEG normal, MRI brain normal, no some stroke, but patient was in alter sensorium. And sepsis was also not that extremely high to explain that about toxic encephalopathy. And there was a ABG mild metabolic acidosis, other parameters were there, sepsis was there, little AKI was there, but there was not an indication to do even dialysis also. So then we have got in deep into the history, then their family members have got the medication details. So then we have seen a drug called lithium in that. So then we have thought probably it might be a possible cause of lithium toxicity. We have sent analysis for lithium levels, and they have come into the toxic levels. Then we have gone to a nephrologist, took the help of a dialysis, just because from the history we got that lithium, we have sent analysis, and the patient was dialyzed, the patient became fine. And as all of us know, the mainstay of therapy, if you suspect lithium toxicity, in the early phase of the illness, you have to do a dialysis. So this was there only because we have gone back into the history, we have asked the patient attenders to bring back all the medications, then showed the lithium, then we got a thought that probably lithium toxicity. So such things will happen in all our critical areas where we have to focus more into their clinical history, their clinical findings, and the past drugs, so that all put together will help us definitely in the management of patients' morality. Thank you, Prasad.
Thank you, Prasad, for the wonderful presentation. Now I request Dr. Krishnamohan Reddy to present a token of appreciation to Dr. Prasad. Now I request Dr. Yogesh to present a token of appreciation to Dr. Krishnamohan Reddy and Dr. Shashidhar. Next, moving on to the next part of the decoding of labs in ICU. We'll be next decoding the common acid-base disorders presented by Dr. Ramakrishna, and I request Dr. Ramakrishna M and Dr. Karthik Munta to chair the session. Sir, I request Dr. Pusti to chair the session.
Good afternoon. My name is Dr. Ramakrishna. I am the consultant intensivist at Malakpet. So today my topic is ABG interpretation, the basics of ABG. Actually this topic is divided into two topics. The first half I will cover the very much basics, and all the complex disorders will be covered by Dr. Yogesh. So we'll move into the topic. The objectives of ABG, what is an ABG, the understanding the acid-base relationships, and general approach to ABG interpretation, clinical causes of abnormal ABGs, case studies, and take-home message. ABG is a arterial blood gas analysis drawn from radial, brachial, or femoral arteries, and it's an invasive procedure. Caution must be taken when the patient is on anticoagulants. And when the patient is on anticoagulants, so if the radial you have to apply 5 minutes pressure, and if it is a femoral, you have to apply nearly more than 10 minutes pressure. So arterial blood gas helps us differentiate between the primary ventilatory deficiencies from primary metabolic acid-base abnormalities. Ideally, actually it should be taken in a pre-heparinized syringes, and a 2 ml syringe should be used preferably, and more than 1 cc should be in the syringe. Generally, we have seen some people taking 5 ml syringes in ABCs, which is not ideal. So ideally is take a 2 ml syringe. And another thing is, if you use more heparin, decrease CO2 will be decreased, and bicarbonate will decrease, and there is a spurious sampling of acidotic sampling will be present. So in the ABG we get an acidosis. Increased temperatures decrease the PO2. So whenever you are sending an ABG, you decide an FiO2, SpO2 and temperature status, you have to send this status. And as the age increases, PaO2 also decreases in the arterial blood gas sample. So 109 minus 0.4 into age we have to, that is the formula, generally ideal formula to see the PaO2 levels. If age is, for example, age is 70, 109 minus 0.4 into 70. That is the ideal thing. I think you all know this. pH, PCO2, bicarb, base excess, oxidation status. This is the primary acid-base pH balance sheet. You see the normal this acid-base balance pH is a very important slide. This is the normal pH 7.35 to 7.45. If the pH is more than 7.45, alkalosis, less than 7.3, acidosis. And less than 6.8 and more than 7.8 is patient will die. All the cellular levels, all enzymes, everything, they stop functioning in the body. So when the cell dies, whole patient dies. So as far as possible, the body tries to compensate to keep the blood pH in this range. pH is the nothing but the H plus ion concentration. We cannot directly measure serum H plus, like serum sodium or serum chloride like this. So it's a negative logarithm of H plus ion concentration. When H plus is more, acidosis is there, and H plus is less, alkalosis. So that is the thing. So maximum body tries by buffering to keep this in this state 7.35 to 7.45, where it is ideal for all mechanisms of enzymatic actions, all things to occur. So this balance should always be maintained in the body. Whenever there is an imbalance between the acid and alkali, when it is not neutral, imbalance occurs to the body and hemodynamic disturbances occur. So we are measuring the concentration of H+. A high concentration of H+ will result in a lower pH. Likewise, a lower concentration of H+ will result in a higher pH. The acids are substances that contain and therefore can release H+ ions. This is also one of the important reactions, especially for the those who are newly entered into the intensive care unit. Most of the seniors, they might know. This is the main, the crux of the ABG, the pH range, compensations, everything. Suppose if you see if H+ is more in the body due to any acidosis, whatever may be the cause. So what the body tries to do is it tries to combine with bicarb, and the reaction is towards the left side. So it forms H2CO3, H2 and CO2. And then CO2 is exhaled by the lungs. Suppose the patient is having the diabetic ketoacidosis in metabolic or any metabolic acidosis. So whatever the H+ ions is increased, it combines with bicarbonate, and the reaction is towards the left. So patient breathes more in order to drive out and exhale more CO2. So whenever you see an acidotic patient, that is called acidotic breathing, to drive out the PCO2, because the reaction is going in the left side. In the same way, if the PCO2 is more because of any opioids or benzodiazepines or any other things, the reaction will go to the right. So what happens is the CO2 combines with H2O, forms bicarbonate, and this H+, what the reaction is coming to the right. This H+ is trying to be excreted by the kidney. So kidney takes over the process of excreting the H+. So this is the main, whatever the compensation, everything. If H+ is increased, this is increased. Bicarbonate and the CO2. So this is a respiratory acid and this is the metabolic acid. You have to find out. And this is the balance which should be maintained always. These are bases which are substances which combines H+ ions, as I already told you. And buffer systems. There are generally 4 buffers in the body. Initially, bicarbonate, blood bicarbonate is buffer, and intracellular and bone buffering, and kidney and lung. These buffers, they make an important action. This is a respiratory component, functions of the lungs. Carbonic acid, approximately 98% of the normal metabolites are in the form of CO2. So excess CO2 is exhaled by the lungs. Metabolic component is the function of the kidney, as we have already discussed. The process of kidney excretes more H+ and reabsorbs bicarbonate, thereby maintaining the balance. This is the normal IBG. This is acidosis and alkalosis. Respiratory acidosis, CO2 is an acid. The failure of the lungs to exhale CO2 results in respiratory acidosis. This is an important slide. This is a Davenport nomogram. Especially it is for juniors. It will be very useful when you get a doubt. You can extrapolate whatever the results you get in an ABG. You can see here all this upper part metabolic acidosis, lower part metabolic acidosis, metabolic alkalosis, chronic respiratory acidosis, acute respiratory alkalosis, acute respiratory acidosis. So you see this is the pH, this is the bicarb, and this side is PCO2. Suppose if I say in metabolic alkalosis side, you can see PCO2 is high, pH is more pH, more PCO2 in metabolic alkalosis side. Bicarb is also high. So this area is a metabolic alkalosis area. This for beginners I am telling. And in this area you see chronic respiratory acidosis area. pH is trying to be compensated, 7.34 to 7.45. Bicarb is more and CO2 is also more. This is a chronic respiratory acidosis. And if you see acute respiratory acidosis, here pH is less, bicarb is less, and CO2 is slightly more. You see more than 40, 50 like that. This is acute respiratory. So this is the Davenport nomogram. When you can Google it, you will find the Davenport nomogram. Especially it will be useful for beginners. The cause of respiratory acidosis, CNS depression, pleural diseases, COPD, ARDS, musculoskeletal disorders, compensation for metabolic alkalosis. This is an acute versus chronic. Whenever you see respiratory acidosis, we have to see the compensation acute or chronic. We'll see later. This is a metabolic acidosis. It can be single or a multiple process. pH is less than 7.35, bicarbonate less than 7.22. And whenever you see metabolic acidosis, then you determine the anion gap. Anion gap is sodium minus chloride plus bicarb. The normal anion gap is 12. If it is more than 12, it is a high anion gap acidosis. Less than 12 and around 12 is normal anion gap acidosis. The causes of metabolic anion gap acidosis are KULT. You can remember KULT. Ketoacidosis, uremia, lactic acidosis and toxins. These four are high anion gap acidosis. Ketoacidosis means diabetic ketoacidosis, starvation and alcoholic ketoacidosis. These three will come under ketoacidosis. Uremia, whatever the cause for uremia will cause high anion gap acidosis. L, lactic acidosis type A or type B can cause high anion gap acidosis. Then these are toxins. Whatever toxins are there, all toxins, methanol, ethanol, all these toxins, they can cause high anion gap acidosis. So you can remember the word cult, KULT cult. Then the non-anion gap metabolic acidosis, we can hard ups, hyperalimentation, acidozolamide, RTA, diarrhea, erythropoietic shunt, pancreatic fish loss and spironolactants. When you see a normal anion gap acidosis, then you can calculate the urine anion gap. If the urine anion gap is negative, it means origin from the gut. And other thing is renal. This is the respiratory alkalosis. Increased pH, decreased CO2 and increased ventilation. The causes are CNS disease, intracerebral hemorrhage, midbrain tumors, H, hypoxia, A, anxiety, M is overventilation, P, progesterone, pregnancy, and salicylate and sepsis. These are some of the causes of respiratory alkalosis. This is also acute and chronic. This is the metabolic alkalosis, increased pH and increased bicarbonate. It is U, chloride resistant and chloride sensitive. Chloride responsive and chloride resistant. Chloride responsive means diarrhea, vomiting, nasogastric, all will be under chloride responsive. Chloride unresponsive metabolic alkalosis means Gitelman syndrome, these medulloccorticoid excess, those will be under the chloride resistant. So with this brief introduction about the acid-base disease, then we will go for the analyzing the ABG when you have a sample. So step 0, there are total 7 steps, step 0 and step 1 to 6. So step 0 is authenticate the ABG. So whenever you get an ABG, if you see some dissimilar results, pH and PCO2 very, very abnormal, when you suddenly get a doubt, first you have to validate the ABG. So for that validation, the formula is 24 into PCO2 divided by bicarbonate. So what the result, H plus result we get, we have to extrapolate with this table. Suppose if you get a sample of H plus sample of 63 and the pH sample in ABG what we have got is around 7.2, that means the ABG is validated. So first we have to see the validation of the ABG. After validation, then you have to go for whether it is acidosis or alkalosis. You know already less than 7.35 is acidosis, more than 7.5 is alkalosis. After determining whether acidemia or alkalemia, then you go whether it is respiratory or metabolic. If PCO2, we have to see the direction of the PCO2 and bicarbonate. pH, PCO2 and bicarbonate we have to see. If there is a respiratory irregularity, PCO2 is abnormal, then there is a respiratory irregularity. In the metabolic abnormalities, bicarbonate is abnormal. Then you see if it is respiratory, you have to see the expected pH. If it is a respiratory problem, we have to see the expected pH. Expected pH should be seen by acute and chronic, both changes we have to see. If you see the expected pH 0.008 into delta change in pH, that means for example in the sample we get a PCO2 of 90, the expected pH we have to see is 7.4 minus 0.008 into 90 minus 40. 40 is the normal CO2. If it is a chronic, we have to see the delta change is 7.4 minus 0.003 into change in PCO2, 90 minus 40. Then we get a sample. So the expected pH, if it is equal, then we can say it is in a compensated. If it is between acute and chronic stage, it is partially compensated. If it is equal to, if it expected to equal to chronic, then we can say it is a chronic respiratory acidosis. Then after seeing the expected pH, then we go to see that if the compensation is adequate or not. Then if after respiratory is over, then we go to the metabolic. As we have already told you, metabolic is anion gap. You have to see the anion gap. What is it, high anion gap acidosis or low anion gap, normal anion gap acidosis? Anion gap is total serum anions is equal to total serum cations. So sodium minus chloride plus bicarbonate. In blood, if there is generally in blood there is a relative abundance of anions. Then the coexist after determining the high anion gap, then we can see the step 6 is coexistent metabolic disorders. This is the delta anion gap and delta bicarb. This will be dealt by Dr. Yogesh. If the delta gap is equal to 1, it is a pure hagma. If more than one associated metabolic alkalosis is there, and if it is less than one associated normal anion gap acidosis. These are some of the examples. The metabolic acidosis, metabolic alkalosis. Then we see the compensations. Respiratory acidosis uncompensated. Because there is no response from the kidney yet to acidosis, the bicarbonate will remain normal. As in the previous slide we have seen the direction of the changes. Partial compensation. The kidney starts to respond to the acidosis by increasing the amount of circulating bicarbonate. Fully compensated means pH returns to normal. That is called a fully compensated. When pH returns to normal, it is called fully compensated. But PCO2 and bicarbonates or levels are still high. Never assume that pH and PCO2 will come to normalcy. They will always be high, but pH can become normal. Respiratory alkalosis. There is no response from the kidney yet to acidosis, then bicarbonate will remain normal. Partial compensation, kidney starts to respond, decreasing the amount of circulating bicarb. Full compensation, pH returns to normal. PaCO2 and bicarb levels are still low to correct the alkalosis. The metabolic acidosis, there is no response from the lungs immediately. Then partial compensation, decreased pH, decreased PCO, decreased bicarb. The lung starts to respond to acidosis by decreasing the amount of circulating PaCO2. So in metabolic acidosis, we have to see the expected PaCO2. In metabolic acidosis and metabolic alkalosis, we see the expected PaCO2. In respiratory disorders, we see the expected pH, acute or chronic. Here, a fully compensated metabolic acidosis, pH return to normal. PaCO2 and bicarb levels are still low to correct the acidosis. This is the metabolic alkalosis. Uncompensated, pH increases. There is no response from the lung immediately in uncompensated state. Partial compensation, lung starts to respond. And full compensation, pH comes to normal. PaCO2 and bicarb levels are still higher. These are some of the examples. 26 years old, visibly anxious, hyperventilating. You can see here respiratory alkalosis in the picture. Case 2, insulin-dependent diabetes mellitus, arrived to the ER, pH is low, bicarbonate is also low. This is metabolic acidosis, compensated partially. Chronic renal failure on diuretic therapy, patient is ICU, dehydrated. You can see 7.52 pH, PCO2 is 55, bicarbonate 42. This is metabolic alkalosis, partially compensated. And patient case number 4, 20 minutes in the arrives in 20 minutes after mechanical MVA, agitated motile clammy skin. So you can see his pH, 7.1, PCO2 60, bicarb is 18. Okay, I am. See, no. Yeah, 27-year-old insulin-dependent diabetes mellitus patient arrives in the institution where he lived. So you see the ABG, pH is 7.15, PCO2 is 22, bicarb is 9. Can you please tell me the ABG? pH is low, acidosis, PCO2 is also low. So both are in the same direction. So both are in the same direction is metabolic component.
What is the diagnosis? What is the diagnosis I'm asking? The metabolic acidosis, ABG interpretation. What is the diagnosis of this case? A patient with type 1 diabetic mellitus comes with a severe metabolic acidosis. So possibly decay. So how you will know what is the next two steps you will do in this patient with ABG? Okay, glucose levels. Next, ketones, urine and plasma, and the third one is once the metabolic acidosis is there. What is the next thing you will see? What kind of metabolic acidosis it is? Anion gap. So if you expect in this case a high anion gap metabolic acidosis with dysglycemia with a urine ketones positive, then probably you will end up to towards a decay diabetic ketoacidosis.
Thank you.
Yeah, you just can brief and then let them answer.
Okay. Chronic renal patient, 75 years old male, chronic renal failure and diuretic therapy, was admitted to ICU, comatose and dehydrated. So you can see the pH 7.52, PCO2 is 55 and bicarb is 42.
So somebody interpret.
Metabolic alkalosis might be due to diuretic therapy.
Yes.
Likely normal anion gap.
Yes. You are right. Case number 4. 43 years old arrives in the ER in 20 minutes after motor vehicle accident, which is injured face on the dashboard. He is agitated, mottled, cold, clammy skin, and obvious partial airway obstruction. pH is 7.1, PCO2 is 60, bicarb is 18. Can anybody tell?
Any other person? Interpret from this side. Bhargava. Take the mic. Hand over the mic. 9 mic though.
pH is 7.10 and PCO2 is 60, sir, 60 millimeters of mercury. Respiratory acidosis with normoxemia, sir, and metabolic acidosis is present.
Acute. Your next step is after he has explained it, acute or chronic. History you know, so obviously it should be acute, but numerically also you should correlate. The formula that you have said.
Motor vehicle accident and acute, sir.
Respiratory acidosis with the metabolic acidosis. Respiratory acidosis expected pH you have to see. Acute means 0.008 into PCO2 minus 40 expected pH. And we have to see for both also chronic 0.003 also we have to see. We have to correlate those things both. (17 years, 48 kg with known insulin dependent diabetes, came to ER with Kussmaul's breathing and irregular pulse. You see the ABG 7.05, PCO2 12, bicarbonate is 5, base S is minus 30. Can anybody explain?
Any diagnosis on this case also?
Young male, ABG suggestive of severe metabolic acidosis with normoxemia, and another clue is Kussmaul breathing with irregular pulse also can be suggestive of diabetic ketoacidosis.
Yes, yes.
Compensation?
Compensation we have to check. Expected PCO2 we have to check.
It is hyperventilating also.
Compensation formula.
The formula for compensation?
Expected
PCO2 1.5 into bicarb plus 8 plus or minus 2.
Winter.
Winter's formula. Is a compensated metabolic acidosis with hypoxemia, and the correction of bicarb. The correction of bicarb formula, anybody can tell. How do you correct bicarb?
One of you, anyone knows the answer, just raise your hand and say.
Apparent volume of distribution into target change in bicarb. So apparent volume of distribution is, the formula is apparent volume of distribution body weight into 0.4 plus 2.4 divided by bicarb. Then we get the number of liters. From there, suppose if the ABG bicarb is around 5, if you want that bicarb to, if you want to bicarb to increase till 15, then into 10 we have to see apparent volume of distribution into 10. You have to see, then that is the required amount of bicarb to be calculated. First half we give in, then second half we give later. Suppose if the volume of distribution is 60 liters and the target change in bicarb is around 10 into 60, 600 ml. So that is how we correct the bicarb. So apparent volume of distribution into target change in bicarbonate, however target you want. Case study number 6. 47 years old, was in PSU for 3 hours, post-cholecystectomy. She had been in 40% of oxygen. The PCO2 is 7.44, pH is 7.44, PCO2 is 32, and bicarb is 22. I think it's appear like a normal ABG. Okay. Then what happened is, actually doctor said to shift to room side after taking ABG. Then this is the ABG. 7.41 pH, PCO2 is 10, PO2 is 148, bicarb is 6, base X is minus 17. Can anybody tell?
First interpret the ABG.
Yeah, what is the acid base status first?
pH is 7.41, sir, which is alkalotic side. So PCO2 is 10, so we have to see the next PCO2, it is alkalotic side, so respiratory alkalosis. But there is a base X is minus 17, bicarb is 6. So metabolic alkalosis, which will lead to the respiratory alkalosis.
Primary is what?
Primary is metabolic acidosis.
Actually, this is not a validated ABG. So first stage, step 0, you have to check. Because patient is about to be discharged to ward side, we cannot find this type of ABG. So that's why we have to get it out. So first we have to validate the ABG. Here the validation is wrong.
No, if it is validated also, will let us take the answer for that question.
No, I think even this slide is kind of how much validated. Oxygen was changed to 2 liter nasal cannula, but here we are having respiratory tidal volume and ventilation.
No, that's actually I deleted, but it came suddenly in this slide. Patient is not on ventilator. This so technical error was there in the ABG. If you want to take juniors, those who are new to ICU, you can take this photo, practice ABGs. Thank you, sir. Thank you.
Yeah, good afternoon, everyone. Nice presentation, Ramakrishna. Actually, so it's ABG is an important part. All of us we are interpreting daily, and most of the things you know, you are aware of the things like how to do. Basically, three parts you are seeing: either oxygenation part, ventilation part, acid-base disorders. Besides that, what I want to add something is, please make a habit of calculation of AA gradient, because AA gradient is very much helpful to know regarding the lung pathology. So if you make it, you will know some certain situations, your PCO2 is high, patient might be having a type 2 respiratory failure, might be having a hypoxia, lung pathology is there or not, maybe it will be helpful for you. That is one point. Second point is, always when you are looking, just don't look at ABG, at the same time please correlate clinically with the patient condition. Because so many situations, you might be also have experienced so many times, that patient condition, patient will be, might be very stable, highly stable, ABG is very bad, patient will be having hyperlactatemia, severe acidosis, something will be there, and patient clinically highly stable. So situations where how it is possible, really it is correlating or not, that's one. Another is, suppose PCO2 is high, very high, patient is in acute respiratory acidosis, and PCO2, even we have, everybody might have seen PCO2 coming with 110, 120, pH of 7.20, 15, something. When you look, so without seeing the patient, you might have not seen the patient. By looking at ABG, you will say, I will intubate the patient. Example I am saying. So if you look at, sometimes this happens, these patients, they come out to just put a airway, oropharyngeal airway, nasopharyngeal, underlying OSA component is there, obese patient or something is there. So they may be helpful. So you please correlate. Patient might be having acute respiratory acidosis. Please correlate clinically and manage accordingly. So that's what I want to highlight. Thank you, Ramakrishna.
Very important point sir said, that clinical, without any clinical picture, don't comment about ABG. That is first foremost important thing. Because half of your diagnosis in ABG is got before you lift the ABG when you look at the clinical scenario. So you get 50% of your answer. 50% of your answer will be basing on those numbers. And about the volume of blood sample also that you draw, many a times we draw less than 1 ml of blood for taking ABG. It should be ideally 1.5 ml, between 1 to 2 ml, right? So if you take less than 1 ml and start interpreting, though the minute changes might be there, but definitely they will cause errors in your electrolytes as well as your PCO2 also. So keep in mind, you might want to preserve hemoglobin in ICU drop, but definitely 1.5 will not make a major change, right? So it is very important.
Thank you, sir, for the wonderful presentation. I would like Dr. Karthik to give a token of appreciation to Dr. Ramakrishna. I would like Dr. Shashidhar to present a token of appreciation to Dr. Karthik and Dr. Prusti. Here. After exploring simple acid-base disorders, complex triple acid-base disorders will be dealt by Dr. Yogesh. I would request Dr. Yogesh to come onto the dais, and I also request Dr. V. Srinivas and Dr. Venkatraman Kola to chair the session.
Good afternoon, all of you. So, after completing a simple acid-base disorder, in next half an hour we'll cover a more complex acid-base disorder. So, a quick revision, whatever was discussed by Dr. Ramkrishna. Whenever we get a ABG, there are certain steps which we have to follow to interpret the ABG. The first step is whether it is ABG is authentic or not. Then looking at the pH, we have to see whether patient is having acidemia or alkalemia. Then next, is it because of respiratory component or metabolic component? Then if it is a respiratory, then we have to see whether it is acute or chronic. Then compensation is adequate or not. If it is metabolic disorder, then look for the anion gap. And if is high anion gap acidosis is there, then look for the gap, that is delta gap. So these steps we are going to follow when we are dealing with the cases. Then a quick revision, as already discussed, we have to see the validity, that is look at the hydrogen ion concentration. So this formula is 24 multiplied by PCO2 divided by bicarbonate. So when the pH is normal, like 7.4, now the hydrogen concentration is around 40. And as the pH is become more acidotic, so the hydrogen concentration it keep on increasing. And when it is alkalotic, the hydrogen concentration keeps on decreasing. Then these are certain formulas which we should know whenever we are interpreting the ABG. So for metabolic acidosis, we know it's a, for compensation, it's a Winter's formula. That is expected PCO2 is 1.5 multiplied by bicarbonate plus 8 plus minus 2. Then for metabolic alkalosis, the expected PCO2 will be 40 plus 0.7 into bicarbonate deficit, or there is other formula also, that is 0.7 into bicarbonate plus 21 plus minus 1.5. Then unlike these metabolic disorders, in respiratory disorders, there is an acute and chronic component. So whenever there is an acute like respiratory acidosis, this change in the bicarbonate, it will be by 1 for every change in PCO2 by 10 millimeter. And when it is a chronic, it will change by 3. Similarly, for respiratory alkalosis, when the disorder is acute, the change in the bicarbonate will be by 2. And for chronic, it will be by 5 for every change in PCO2 of 10. Then we should also know, like looking at the pH, we should also able to know whether the disorder is acute or chronic. So whenever this disorder is acute, the change in the pH, it will happen by, there will be, we have to multiply it by 0.008 for every change in PCO2 of 1. And if it is chronic, we have to multiply it by 0.003 for change in the PCO2 of 1. Then there are certain further formulas, like we should be able to calculate the anion gap. That is given by formula sodium minus chloride plus bicarbonate. And then the last step is like calculation of delta gap. So a change in the anion gap and divided by the change in the bicarbonate gap. So normally whenever there is a change in the anion gap, the body will try to compensate by the same amount of change in the bicarbonate. So this ratio will always be 1 if it is a pure disorder. But if there is an additional disorder is present, then if it is more than 1, then we have to suspect there is an additional metabolic alkalosis. And if it is less than 1, then we should suspect that there is an additional hidden non-anion gap metabolic acidosis. So with this brief revision, we'll go to the cases. A 70-year-old woman with a history of prior ventral hernia repair with mesh is admitted to the ICU for a small bowel obstruction requiring a serial examination, nasogastric tube decompression, IV hydration and correction of electrolyte abnormalities. During next 24 hours, her pain worsens and there is a significant villous drainage from the nasogastric tube. Her lab reports are like sodium 149, potassium 3.3, chloride 105, bicarbonate 17. And albumin is 4, and ABG is showing pH 7.5, PCO2 24, PO2 90, and bicarb is 17. So can anyone interpret this ABG? pH is 7.5. So is it alkalosis or acidosis? Acidosis. Then what next? PCO2 is 24, bicarb is 17. Is it metabolic or respiratory? It's a respiratory alkalosis. So if it's a respiratory alkalosis, next step will be whether it is acute or chronic. Okay. Okay. Just before going for the this one, as I told you that we have to see whether the ABG is valid or not. So if you calculate for this patient, our PCO2 is 24 and bicarb is 17. So that calculation comes around 33.8. So for pH of 7.5, this hydrogen concentration is 32. So we can consider that this ABG is valid. Then we were up to step 1, that patient is having respiratory alkalosis, whether it is acute or chronic. What is the formula for acute? We have to multiply it by 0.08 for every change in the PCO2 of 1. And for chronic, we have to multiply it by 0.03 for every change in the PCO2 of 1. So it is the difference actually. We have to consider PCO2 normal is 40. So our PCO2, 40 minus our PCO2. So that for that difference, how much is the actual corrected pH? So if we calculate, for acute respiratory alkalosis, it's coming around 7.52. And for chronic, it is around 7.44. So which is closer to our given ABG? First one. So patient is having an acute respiratory alkalosis. Okay, till now it's okay. Then what about the compensation? So as I told you, for acute respiratory alkalosis, the change in the bicarbonate will happen by 2 for every change in the PCO2 of 10. So here, how much is the change in the PCO2? It is 16, right? So we can consider, like, if you consider it's 15, so there should be a change of 3 milliequivalent. Normal bicarbonate is 24. So 24 minus 3, 21. So our, according to our calculation, it should be 21. But what is the bicarbonate given in our ABG? 17. So it is lesser than 21. If the value is lesser than 21, then additional what disorder is there? Metabolic acidosis, correct. Then there is a metabolic acidosis. So what next we'll do? We'll go for an anion gap. Okay. So here anion gap, sodium minus chloride plus bicarbonate. So it is 27. It is normal or high? It's a high anion gap metabolic acidosis. Then the last step, delta gap. So delta gap is change in the anion gap divided by change in the bicarbonate gap. So here after calculation, it is coming around 2.1. So as I said, it should be compensated. It should be equal, that it should be 1. So it is more than 1. So it is 2.1. So it suggests a metabolic alkalosis. So what 3 disorders came while interpreting this ABG? Yeah, and what could be the reason for each one? Yeah. See, this was 70-year-old lady with hernia repair, serial examination, nasogastric tube decompression was there, and then she next 24 hours her pain worsens, and this was the lab.
See, no ABG should be interpreted without a clinical context. Okay, all of you sitting here are going to be the clinicians at the bedside in future. Okay, all the ABG interpretations whichever you are doing right now, he said there is a respiratory alkalosis, there was a metabolic acidosis, and when we further analyze that metabolic acidosis with the gaps, delta gaps and all, then we could also realize there is a metabolic alkalosis component. Can you just imagine, we are going complex to complex. Initially we said in the first part whether acidotic or alkalotic, whether metabolic and respiratory, whether compensated or not compensated. Now we are talking about beyond that, from acidosis to alkalosis to metabolic to respiratory to compensated to not compensated, to a stage where we are saying the same patient can have both metabolic acidosis and in the same patient in the same time can also have a metabolic alkalosis. So these are all called complex acid-base disorder or called triple acid-base disorders. Are you all able to follow? We expect all of you here are postgraduates in critical care. And in the body, the ABG interpretation may look very simple outside on a table. But when we come to the cellular homeostasis, when we come to the real-time situation, these are the problems which we face. Okay. Now in this clinical context where a lady, an elderly lady, looks like a subacute or acute small bowel obstruction, was pouring out his gut by some form of vomiting, had a 3 components in ABG. So some of you, to pick up from the last, Ganesh, pick up the mic and answer what are the 3 reasons of her respiratory alkalosis. You can sit. What is the cause for metabolic acidosis and what is the cause for metabolic alkalosis?
The cause of metabolic acidosis may be maybe some acute kidney ischemia of bowel, sir, and cause of metabolic alkalosis may be due to loss of nasogastric decompression, causing loss of so metabolic alkalosis causes nasogastric decompression, sir, and cause of metabolic acidosis is bowel ischemia or secondary to acute kidney injury for this patient. And respiratory alkalosis may be metabolic alkalosis cause metabolic acidosis. Pain is one of the reason, and metabolic acidosis is try to compensation mechanism.
Yes, very correct. So basically, his metabolic lactic acidosis is because of worsening sepsis from the ischemic small bowel. Then metabolic alkalosis is because of the vomiting and the nasogastric tube drainage. And because of the pain, patient is hyperventilating, that causing the respiratory alkalosis. So we'll come, these are the common causes of high anion gap metabolic acidosis. This already covered. Coming to the case 2, a 57-year-old man with a history of type 1 diabetes mellitus is evaluated in the ER for severe abdominal pain, nausea and vomiting. Ketones are detected in his urine. After establishing IVSS and beginning the IV hydration with 0.9% normal saline, he is admitted to the ICU. His ABG in the ICU suggests pH of 7.12, PCO2 40, bicarb 17, sodium 145, potassium 3.1, and creatine 1.65, albumin is 2.5. So what is the disorder here? Mahesh, will you start? So pH is 7.12, bicarbonate 17, PCO2 40. What is the primary disorder? Yeah, correct. From here onward, we'll consider that all the ABCs are authentic just to save the time.
So metabolic acidosis, sir.
Yeah.
So next I'll go for compensation. 17 times 1.5 times means 17 into 1.5 times plus 15 plus or minus means plus 8 plus or minus 2. So 17 1 times is around 24 plus 8 32 plus or minus 2. So PCO2 should be around
35 plus minus 2, but our PCO2 is on the higher side. So what you will suspect?
So combined respiratory acidosis is also there.
So one is metabolic acidosis with respiratory alkalosis.
And respiratory acidosis.
Yeah.
Along with after that metabolic acidosis, and again I'll go for anion gap.
Yes.
So next 145 minus 95 is around 50. Plus bicarbonate is around 17. So around 33. So high anion gap metabolic acidosis.
Yeah, very correct. So till now we are up to high anion gap acidosis. As he correctly said, first step metabolic acidosis, then he looked for the compensation. Then since the PCO2 in the given ABG was on the higher side, so there is a concomitant respiratory acidosis present. Then he calculated the anion gap. So that is 33. It is a higher anion gap. Anything else in the given lab values which will change the anion gap? Albumin. Yeah. So how it affects our calculated anion gap?
Calculated anion. So difference between 4 minus the present albumin into the at present anion gap.
Yes.
So 4 minus this albumin value is 2.5. So 1.5
the corrected albumin corrected anion gap is given by the formula whatever observed anion gap plus 2.5 multiplied by normal albumin minus observed albumin. So with that calculation it comes around 36.75. So still it is a high anion gap metabolic acidosis only. So why albumin it causes a falsely low value in anion gap? Because it is a negatively charged and it contributes to anion gap. So when albumin levels are low, the our calculated anion gap it comes less. Then about delta gap.
Next step is delta gap.
Delta gap, yeah.
So change in anion gap by change in bicarbonate. So anion gap normal.
So here to save the time, our calculated anion gap was 36.75 minus normal anion gap, that is 12, and 24 is normal bicarbonate minus 17. So that ratio comes around 3.5. So what is additional disorder?
Metabolic alkalosis.
Yeah. So here again, a triple disorder is there. Patient is having a high NAN gap metabolic acidosis. It is most likely because of diabetic ketoacidosis. Then again, the vomiting is there, which explains the metabolic alkalosis. And because of pain, sometimes patient can have hyperventilation because of pain, like even in the previous scenario, where sometimes patient can have a decrease in the ventilation causing the respiratory acidosis. So with this, these are the common causes of metabolic alkalosis. They are broadly divided into the chloride responsive and chloride unresponsive alkalosis. Basically, chloride responsive alkalosis will have a urinary chloride of less than 20, and unresponsive will have more than 20. And they will, this chloride responsive metabolic alkalosis will respond to our treatment with normal saline. Then we have to further evaluate whether the loss of bicarbonate, is it because of the GI system or renal system. So in the GI system, the urinary gap will be low, while the loss is because of the renal system, the urinary gap will be increased. This normally urinary gap is calculated by the formula urinary sodium plus potassium minus chloride, and it ranges from -10 to +10. So with that, we will come to the case number 3. Here it is a 70-year-old male with the ESRD, COPD and diabetic presenting with the cough. He missed hemodialysis today. His ABG, which is present ABG, is 7.12, PCO2 65, oxygen is 104, and bicarbonate is 18. And there is he has provided a ABG which was taken 3 weeks before. That time ABG was pH 7.32, PCO2 was 70, and bicarbonate is 38. So and sodium is 144, chloride is 94. So Shilpa, can you interpret this ABG? If you look at the ABG, pH is 7.12, PCO2 is high, and bicarbonate also low. So it's a clear-cut mixed acidosis, right? Yeah. Then what next?
Whether it is acute or chronic, sir. So bicarbonate change plus in acute it is 0.008 into.
Okay. In this case, it's already a mixed acidosis, so we'll focus on metabolic acidosis, and we'll go the next step, that is anion gap. Okay. So, what is the anion gap here? It is 32. So it suggests a high anion gap metabolic acidosis. So, and look, if you look at the previous ABG, which was 3 weeks before, the pH was 7.32, PCO2 is 70, and bicarbonate is 38. So if you calculate this ABG, it comes around like patient is having a compensated chronic respiratory acidosis. Why I have taken this ABG is to just when we are calculating a delta gap here, we will not take bicarbonate 24 as a normal, because he is in a chronically compensated state. His already bicarb is around 38. So when we calculate a delta anion gap and delta bicarbonate gap, both values comes around 20 when we consider bicarbonate as 38. So this patient is basically having a acute primary metabolic acidosis from decay and renal failure in the setting of primary chronic respiratory acidosis from the COPD. Just that was the point to tell here. These are the common causes for respiratory acidosis. Already we have covered that. Then coming to the case 4, you are asked to review a 15-year-old male who has been receiving a treatment for asthma in the ER for 3 hours. The concern is persistent hypocapnia. He is now tachypnic with a mild generalized expiratory wheeze, and the following are the serial data from the arterial blood. So there are 2 ABG, one was taken at 7 o'clock and another was taken at 10 o'clock. At 7 o'clock, pH is 7.5, PO2 is 80, PCO2 30, bicarbonate 23.1. And at 10 o'clock, the pH is 7.39, PO2 is 175, PCO2 is 30, and bicarbonate is 17.9. So, as Dr. Prushti sir said, there is importance of calculating AA gradient. So, can you tell what is the AA gradient, and can you interpret AA gradient here? Girl next to Shilpa, since she is giving so many answers. What is AA gradient? No, what is the formula? What is the AA gradient stands for? It's a alveolo-arterial gradient. So what is the difference between the oxygen at the alveolar level and the arterial level? That we have to see. Okay. So it is given by the formula barometric pressure minus water saturated pressure, vapor pressure of water multiplied by FiO2 minus PCO2 divided by the respiratory quotient, that is 0.8. And this AA gradient, it will vary with the age. So that for that formula is age plus 10 divided by 4. So here at 7 o'clock, if we calculate our pulmonary alveolar oxygen, here 760 minus 47 multiplied by 0.5, PCO2 is 30 divided by 0.8, it comes around 319. And at 10 o'clock, our this is around 319, and our arterial oxygen is 80. So if we minus this 80 minus 3 from 319, it comes around 239. And at 10 o'clock, our AA gradient is 144. So there is an improvement in the AA gradient from 239 to 144. Are you understanding this, or I am fast? Okay, now. So there is an improvement in the AA gradient. It was at 7 o'clock, it was 239, and at 10 o'clock, it is 144. So that what it suggests? Patient is improving or becoming bad? What? It is sir, please. Since there is a decrease in the AA gradient, so patient is improving or becoming bad? Improving, yeah.
If your AA gradient is high, what does it indicates? See, normally your alveolar PA or P capital A, that's alveolar oxygen pressure, after calculation will be somewhere around 100 or 110 or 20, whatever it is. And your gap will be somewhere in 10, 5 or 12 or something. If that gap is extremely high, what it indicates? If there is a gap between alveolar and arterial, yeah, we have two reasons there. You have either a shunt or a vacuum mismatch. Okay, so if these are the components, if that is high and if it is narrowing, that itself it indicates that it is improving.
Yeah. So second question, can you describe the acid-base status at 7 o'clock and 10 o'clock? Kondal? At 7 o'clock, what is happening at ABG?
Respiratory tuberculosis.
Okay. At 10 o'clock? Metabolic acidosis. So patient is converting from the respiratory alkalosis to the metabolic acidosis. Can you have any explanation for that? Patient is treated with salbutamol nebulization, and it is known to cause a lactic acidosis. So at 7 o'clock, patient was having a respiratory alkalosis, which is changed to metabolic acidosis with compensated with additional respiratory alkalosis. So at 7 o'clock, patient was having acute respiratory alkalosis. At 10 o'clock, patient is having high anion gap metabolic acidosis with respiratory alkalosis. That is because of superimposed lactic acidosis caused by the salbutamol. And these are the causes for respiratory alkalosis. Then coming to the case 5, a 56-year-old man was admitted to the ER because of the decreased level of consciousness. Vital signs were normal. Besides reporting a regular alcohol consumption, relatives reported a recent progressive weakness and 5 kg weight loss. Laboratory findings on the admission were remarkable for moderate hypoglycemia. His ABG suggests pH of 6.87, PCO2 14, bicarb of 4, sodium 140, chloride 99, and serum lactate of 21. Then patient was started on 25% dextrose in the ER. When he reached to the ICU, his GCS dropped further. He required intubation and mechanical ventilation. So can you interpret this ABG? Sorry? So 6.87, it is metabolic acidosis. Compensation? Is it compensated or any additional disorder is there? 4 plus 2, 6 plus 8, 14 plus minus 2. So it's a compensated metabolic acidosis. Well, then what about the anion gap? (140 minus 99 plus 4). So high anion gap. So a patient is having a pure high anion gap metabolic acidosis. So our next question, what can be the cause of high lactate level in this patient? And what is the cause of deterioration in his GCS? And how can you prevent it? What must have happened? Go to the history again.
Focus is not to just treat the ABG. ABG is a reflection of some clinical disorder in the patient. Your point is to diagnose, recognize and correct it so that your ABG will get better. So there is a clinical context which is suggesting a clue towards a high anion gap metabolic acidosis in this patient and is worsening. In the ER after dextrose supplementation he worsened. So what is the diagnosis?
Yeah. Why we should give it before or during? Means they say either it should be given prior or it can be given along with dextrose, but not after. Why?
There is increased anaerobic metabolism, so there is a worsening of lactic acidosis. So we have to supplement thiamine and then give dextrose.
Because thiamine is required for the metabolism of whatever carbohydrate load we are adding to the patient. For that again thiamine is required. Patient is already in a deficient state. So that further it will decrease the thiamine level and patient will land up into the vernix encephalopathy. So to prevent it, we have to give either along with or prior to giving the dextrose. Coming to the case 6, a 29-year-old male with a history of type 1 diabetes mellitus is seen in our office for routine insurance examination. On physical exam, he is well developed, well nourished. There is no apparent distress, blood pressure and other vitals are normal. His laboratory data suggest potassium is on the higher side, chloride is on the higher side, and ABG, pH is 7.35, PCO2 30, PO2 105, bicarbonate 16. So who will interpret this ABG? Srikanth?
Because of anxiety, he is having respiratory alkalosis.
Sorry?
So because of anxiety, he is having respiratory alkalosis, sir.
pH is 7.35 and bicarbonate is 16. So what is your primary disorder here? Is it alkalosis or acidosis? PCO2 is 30. If PCO2 is 30 and pH is 7.5, then we have to look for the bicarbonate. Bicarbonate is low. It's metabolic acidosis, right? Isn't it? So he is having a metabolic acidosis. The next step, what? You will look for the compensation. Actually, there are certain questions. What is the primary acid-base abnormality here? Metabolic acidosis. Then calculate the anion gap. So anion gap is sodium is 140, bicarbonate 16, chloride 112. Normal. So patient is having normal anion gap metabolic acidosis. Is there any compensatory mechanism for this abnormality? What happens? Body tries to hyperventilate for compensation. What is the predicted compensatory response? How much should be the PCO2? Winter formula? It should be 30, 32 plus minus 2 and our this thing is 30. So it's a compensated. Is it a simple or mixed disorder? Simple disorder. So what are the common causes for non-anion gap? So patient is basically having a non-anion gap metabolic acidosis. So what are the common causes of non-anion gap metabolic acidosis? Tell me 2, 3. So this is a mnemonic for that. Any acid infusion, aldosterone inhibitor, compensation for respiratory alkalosis, renal tubular acidosis, especially in this patient. Then ureteral diversion, extra alimentation, hyperalimentation, diarrhea, or other any gastrointestinal loss. So basically our patient was having a type 4 RTA. His potassium was on the higher side, hypercalcemia with normal anion gap acidosis. And why it happens? Because there is a decreased response of aldosterone at the cortical collecting duct. Then coming to the final case, a 50-year-old African American gentleman with a sickle cell disease and CKD is admitted to the hospital because of his deteriorating condition. This was assumed to be due to the sickle cell crisis, evidenced by the severe anemia and increasing bone pain. The anemia did not, however, appear to be hemolytic in nature as it would be expected in sickle cell crisis. and despite the blood transfusion, he grew worse. After 4 days in the hospital, his condition further deteriorated with a change in mental states. He became more drowsy, disoriented, slurred speech, and progressed to the stupor. His laboratory testing suggests sodium of 131, chloride 112, bicarbonate 19, pH 7.3, PCO2 36, and bicarbonate of 19. So, can you interpret this ABG? Shrikant, chalo, start. Okay, metabolic acidosis, compensation. See, the formula is 1.5 into bicarbonate. I will tell you a simple step. Like bicarbonate is 18. Whenever we are calculating, multiplying by 1.5 means you are adding half of that. So, if bicarb is 18, add 9. Bicarb is 16, add 8, whatever, half of that. Then plus add 8 more, plus minus 2. So, you will have a fast calculation. So, here it is 19. So, if it is, suppose it is 18 plus 9, how much? 27 plus 8, 35 plus minus 2. So, it's a fast calculation. Okay. So, PCO2 is almost 36. So, is it compensated or not? Compensated. Then what about an anion gap? Is it normal? Sodium is 131 plus 112 plus 19. It's a 0. So, do you know any causes where negative anion gap or minus anion gap is there? Say loudly.
Be loud.
Like bromide.
Very good. Bromide intoxication.
Calcium.
Lead intoxication. Hypercalcemia. And so these are the causes, disorders we have already discussed. If there is severe hypoalbuminemia or monoclonal and polyclonal gammopathy, hypercalcemia, hypermagnesiumia, pregnancy, multiple myeloma, and then drugs like bromide or lithium low overdose, these all can cause a decrease in the anion gap. It will be lesser than the normal anion gap. So in our patient, on further evaluation, we found that the patient is having a multiple myeloma. And that's why he was having a normal negative anion gap acidosis. So with this, I come to conclusion of my slide. Thank you.
Yeah, very well presented, Yogesh. So probably now after this, from Ramakrishna, we have understood what exactly ABG tells us, acidosis, alkalosis, primary, secondary, tertiary, as Venkat has clearly said. Now we are in phase where we are seeing mixed disorders, primary, secondary, tertiary. See, what is this all very important for us? In what way this is trying to help us in the management is, see, a clinical scenario is very important. We should understand which is a primary abnormality, which is a secondary abnormality, which is a tertiary. And we should sit with the clinicians and or a team of critical care specialists to know what to treat first, which is the basic abnormality and which is the most important abnormality. So this ABG abnormality is what we are seeing should tell us or give us a clue towards the treatment part, and that's what actually helping us. See, rather than knowing other secondary or mixed, you try to treat the tertiary component, it will be harmful for the patients. And as Pushti sir has clearly tell us and stress once again that always try to treat the patients, not the reports. So never ever jump to treat a pure simple ABG abnormality. Always look into the clinical scenario, correlate with the clinical scenario, whether it is correlating with your clinical scenario or not. If there are even a fraction of doubt you feeling that it is not correlating, always look into the technical errors. If possible, take a repeat ABG. Thank you.
Thank you, sir.
Now I would like to invite Dr. Venkatraman Kola to present a token of appreciation to Dr. Yogesh. I would like to invite Dr. Kaladar to present a token of appreciation to Dr. Venkat and Venkatraman Kola and Dr. Srinivas. going from acid base. Now we will be decoding the hematology labs. The speaker will be Dr. Saroj Kumar Prosti, and I invite Dr. Vamshi Krishna Reddy and Dr. Deepak to chair the session.
Yep. So good afternoon, everyone. So it is my pleasure to have here Dr. Vamshi Krishna Reddy and Dr. Deepak here as my moderators here for this topic. So this is a very important topic, I feel. So many things clinically when we look at the patient, there are a lot of challenges at the bedside. When you look at the hematology reports and along with the clinical correlation for a diagnosis, for all critical care people or emergency department people, it's very difficult for us to diagnose and sometimes. So we should have something basic ideas. I think this topic is not, it's very difficult for you all, but still some of the scenarios we should not miss. So for which I hope everyone of us will learn something from this type of scenarios which will be helpful. So basically there are in the hematology red blood cell series, white blood cell series, platelet count and coagulation parameters are there. So all the scenarios, maximum scenarios I have taken from except the WBC series, all other parameters I have taken. So we'll go through the scenarios. Scenario 1, a 72 years male presented with progressive bilateral pneumonia with onset of symptoms in 10 days and required mechanical ventilator support, vasopressor support for a septic shock. On examination, patient had rashes all over the body, more in the lower limbs, and patient had a cold extremities, required NORAID infusion for the shock, but he was non-oliguric and had a clear urine, and he had a core temperature of 32 degrees centigrade. His labs had a kind of severe anemia, hemoglobin was 4.9, and leukocytosis, platelet count was borderline, around 1.4 lakhs, and retic count was 10%, LDH was 2140. And this was the clinical picture when we took a photograph of this patient. The picture was like, what is your impression from this history and examination finding? Yes, be louder.
Livido reticularis.
Please tell me. Yeah. Anything further, how to do, what to do actually? What is your impression from that? Yeah. Yeah.
Like a typical bacterium, livido reticularis is the finding that is shown in the slide.
Yeah. So, yeah. So, very good. So, if you look at the clinical scenario, so one is bilateral, patient had a pneumonia with sepsis, and second thing is patient rashes all over the body and core temperature was 32, means patient had hypothermia. That is most important part. Second point is patient is having hemolysis. So hemolysis, why, how could you know? The hemoglobin is less and there is a retic count has increased, LDH has also significantly increased. So all this suggestive of hemolysis. Yeah.
See, it is very obvious that there is a hemolysis going on. So there are very many clues that this patient had a sepsis, there is a rash. All
I
emphasize there is one component in the vitals which is suggesting towards it. Severe hypothermia. So
yeah.
hypothermia.
Yeah, yeah. Severe hypothermia with hemolysis. What do you think first?
Combine both of them together.
Then what happened? Your pathologist called you. So this was the picture in the smear.
What is this picture suggesting? Particular, what is the peripheral smear suggest?
Yeah. Yeah, it is called as a agglutination of red blood cells. Okay. So now again you come to a conclusion, diagnosis. Now you no need to do anything extra investigation for that.
Can you combine all of them? There is a hypothermia, there is a hemolysis, there is a agglutination, and there is a pneumonia. Cold agglutination.
Very good, very good. So it.
Cause etiology in the pneumonia.
Mycoplasma.
Cold agglutination caused by which organism?
Yeah. So so now diagnosis is clear, but here we need to emphasize that differential diagnosis will be there are only two conditions. Patient will have a hypothermia with hemolysis. Am I right? So two conditions. One is paroxysmal cold hemoglobinuria. Another is cold agglutinin disease, or a secondary cold agglutinin syndrome. These two conditions where you will get a hemolysis with hypothermia. Another cryoglobin is related to hypothermia, but the hemolysis picture will not be there. So that may not be a differential diagnosis. But only the paroxysmal cold PCH and cold agglutinin disease will be our differential diagnosis. So what is the difference between your PCH and cold agglutinin disease? So if somebody can answer, it's good. If otherwise, I'll tell here. So say usually the paroxysmal cold hemoglobinuria usually present in the childhood, whereas cold agglutinin disease in the elderly or adults usually they present. And the mechanism of hemolysis in PCH is intravascular hemolysis, whereas mechanism of hemolysis in the cold agglutinin disease is extravascular hemolysis. So you will see a hemoglobinemia and a hemoglobinuria in a PCH, whereas you will see only hemolysis picture which is evident by your retic and LDH count and other parameters which is helpful for your cold agglutinin disease. And if you do a Coombs test, in both the conditions it will be positive. But here the Coombs test is based on your complement based Coombs positive. Whereas in a warm antibody Coombs positive, there you will get a IgG positive. So that is the difference we need to know here. Okay. So here we need to know, I think extravascular hemolysis and intravascular hemolysis, you can differentiate easily. Besides your LDH and retic count, the most important parameter we concentrate is hemoglobinemia and hemoglobinuria. So these two things are present, intravascular hemolysis. If these are not present, then it is extravascular hemolysis, because retic and LDH count will increase in both the conditions. Okay. And diagnostic framework for hemolysis is important for us. Just will not take much time, but it is important because in ICU setups, those patients who are coming to hospital with anemia, maybe multiple reasons, like basic three mechanisms as a bone marrow production problem, or a anemia means blood loss, or a hemolysis. Whereas those patients who are coming developing anemia in the ICU, then there usually marrow production problem is not a cause for anemia. So only two reasons, either a loss or a hemolysis. These two things, if you remember, your evaluation will be easy. So for usually intravascular hemolysis, that is a reason for that. Why marrow production is not a cause for anemia? Because only 10% of the red blood cell, the hemoglobin, will be lost per day in 24 hours if there is a marrow failure. 100% marrow failure. Suppose somebody is having a 10 gram hemoglobin, next day it will be 9.9 gram. So it's 1% is very, very less. So hemoglobin will drop by 0.1 gram is not significant. So to cause anemia. So if there is a disproportionate fall of hemoglobin, marrow failure is not the cause. So either you need to, these two things you have to exclude. For hemolysis, Usually the causes for broadly you need to remember intravascular causes and extravascular causes. In the intravascular causes, DIC is the most common cause you experience in the ICUs, and microangiopathic hemolytic anemias, HELP syndrome, transfusion related reactions, and PNH. PNH is a very rare disorder, but these are the usual causes of intravascular hemolysis. Extravascular hemolysis, autoimmune hemolytic anemias, different drugs and different enzyme defect, membrane defect disorders, and hemoglobinopathies, and different infections, complicated infections, malaria, babesiosis, and some other hypersplenism, Wilson's disease, different toxicities are responsible for your extravascular hemolysis. So to work up, it is also very simple. If you do a workup also, peripheral smear most of the time, your peripheral smear will be helpful. If you look different abnormal cells in your pathologist will call you, are you looking for a different cells, abnormal cells? So are you looking for a spirocytes? Are you looking for cystiocytes? Are you looking for a hypochromic anemia? Are you looking for a different infection? So depending on the type of your peripheral smear, you can easily diagnose the hemolytic anemia. Coming to scenario 2, a 75 years male presented with 2 months history of gradually progressive dyspnea with weight loss and lethargy. He had past history of CVA and with left hemiparesis and had hypertension. He was on aspirin and perindopril, and he had a residual hemiparesis, and he was little pale and mild jaundice, and labs were showing like hemoglobin of 5 gram, MCV of 109, TLC of 2300, platelet of 45,000. And urobilinogen was positive, retic count was 5%. What is the most appropriate investigation we will go for it in this situation? Yeah, tell me now what next appropriate level, should you go for a bone marrow? Should you go for a Coombs test, endoscopy, serum heptoglobulin, or a B12 concentration? Okay, but here, yeah. Yeah, B12 is yeah, correct. Yeah. So B12 is a common cause for B12 deficiency is a common cause for your pancytopenia. I agree with that. So what is the first investigation you want to do?
B12 takes its time. Okay, you send a sample. What is the immediate investigation or a first investigation which
yeah.
Hitting towards? Yes, it's very all high-fi investigational. What is the basic thing which we do day in and out in a ER or in a ICU?
Again, I'm just look at the scenario and the lab values.
MCV is high. MCV is high, sir, in this
yes,
case. MCV is high.
What is the diagnostic view of a B12 deficiency in a peripheral smear?
Hypersegmented neutrophil and megaloblasts.
The more the segments, the more severe is the B12 deficiency or a folate deficiency, whatever is the first.
Yeah. So this here, MCV has raised. Yeah. So MCV has raised means it's a macrocytic anemia. And bone marrow, see, if you come to the investigation, bone marrow aspiration is not going to help you here. And another point is a 5% retic count. That is what suggests your bone marrow is not failed. There is a production is there. Suppose if there is a failure of bone marrow, retic count also will not be produced. Okay. So it is because as you told, B12 macrocytic anemia, the most common causes for macrocytic anemia, folate deficiency, B12 deficiency, and pernicious anemia and hereditary spherocytosis and some of the toxicities. Okay. Now coming to scenario 3, a 42 years woman with history of SLE presents with fatigue. She was receiving anti-TNF therapy. However, she had worsening fatigue. Her vital signs were normal. She had a mild jaundice and fading butterfly rash on her face. The spleen was palpable. Diagnostic testing results showing like this. She had low hemoglobin and she had a retic count of around 4%, platelet count around 4.5 lakhs, and LDH was around 400, indirect bilirubin of 3.